Yeah, so shall we?
Yes, ma'am, please go ahead.
Okay. So, good evening, everybody, and welcome to this FOGSI ICOG course on perinatal mental health, along with AICC RCOG. At the outset, let me thank Dr. Sheila Mane and Dr. Pratik Tambe for, doing this, planning this course on perinatal mental health. As all of us realize, this is a very important aspect of care of women where we really don't have that much exposure. And it's we have as a group of obstetricians along with support from psychiatrists who are specialists in perinatal mental health, focused on perinatal mental health issues over the last few years. But this course is actually a step up from that, where we are actually including all aspects of mental health care in women, whether it is gynecological conditions, whether it is fertility, whether it is menopause, as well as the perinatal and the postpartum aspect. So over the next 3 days, there's a lot of ground to cover, and I am quite excited about this course, and as are all the faculty. So let me once again thank ICOG for this opportunity, and also thank the psychiatric team, Dr. Prabha Chandra, Dr. Ashlisha, Dr. Shubhangi, and Dr. Parul for joining us and helping us put this together. With that brief introduction, I will pass on and invite that we start the program with a prayer.
Poonam, sound is not there.
I think Dr. Bhaskar Pal is not able to join just now. So can I request Dr. Sheila Mane to say a few words?
Good evening, everybody. Thank you, everyone, for joining for this our third certificate course of this year. We already finished 2, endometriosis and infection. And I thank Dr. Umara for joining with us for this very important issue and the certificate course on mental health. And as she said, that they have covered almost all the age groups, as it is not only the pregnancy or the prenatal, which is very important, I think. And I thank Dr. Bhaskar Pal, who suggested me first to have this course with Dr. Umara, with RCOG. So I thank Dr. Bhaskar Pal as well. And I think Dr. Umaram has already given the overview. And I think we have a very prestigious faculty today, those who are into this field, that is psychiatry. So we have Dr. Prabha Chandra, and she is the director, Nemans Hospital, Bangalore. as well as we have Dr. Ashlesha Bagdia, and then Dr. Runa Benjamin, as well as Dr. Shamanna. And today we are, I think they are going to discuss about the mental health in reproductive life, as well as the how to do the screening in gynecology, as well as even related to ART and infertility, and PMDD also. And lastly, there will be a panel where there will be a case-based discussion. So I think excellently, so I think structured program by Dr. Umaram, and I'm happy to see that already people have started joining, and we have more than 900 registrations today. So I'm sure that most of our FOGSians will be benefited with this. So once again, on behalf of ICOG, I welcome all of you. There are some senior people who have joined. Dr. Pushpa Srinivasova, Bangalore. Madam is a senior most obstetrician and gynecologist from Bangalore. I welcome you, madam. Thank you for joining. Thank you, Dr. Uma.
I now, I think we will get started with the program, and I request Shaijas to take on the proceedings. I only wanted to say that some of the sessions are going to be talks, but a lot of this is structured as a case-based discussion between an obstetrician and a psychiatrist, so that we get the message across as to how to provide care. And we have given ample time for interaction. So please use the the Q&A box or the chat box to send in your questions, so we can take them during the interaction as well.
I would like to say Dr. Pratik Tambe to say a few words, and if Dr. Sarita is here, Dr. Sarita Valera.
Dr. Sarita is here. Let her go first.
Yes, Sarita.
I saw her just now.
Dr.
So
Maybe the patient simply can't speak.
Okay, you finish, Pratik, then let her.
Okay. Anyway, welcome everybody to this wonderful perinatal mental health course. And this is something which is very untouched in our part of the world, in the SAFOC countries, South Asia, especially India. But this is a very big emerging area as far as health issues and emerging concepts are concerned in the Western world. We are judged as OBGYNs not only in the quality of the obstetric care that we provide, but also how we are able to provide good, efficient, and timely support for mental health issues, not only in the peripartum period, but also in the antenatal period. This will be the focus of this entire 3-day certificate course. I'm sure all of us will learn from these wonderful experts who have collaborated and come together. Without further ado, I wish them all the very best, and I hand over back to you.
Dr. Sarita. Sarita?
Yes, ma'am, I'm here. I thought I will welcome on the last day, but yeah, I can see that everybody's eagerly waiting, and there's a fantastic lineup of speakers and lovely topics. So I wish the course all the best.
Okay, thank you. I think Shaijas, you can take over.
Yes, madam. Yes. Can I have the CVs of the chairpersons, please? Dr. Jyotika Desai and Dr. Seema Hakim would be the chairpersons for session 1. Yeah, Dr. Jyotika Desai, as you all know, is a senior consultant at Dr. P.R. Desai Hospital at Bangalore, a DNB teaching faculty, past president of Bangalore Society, and president of Bangalore Menopause Society between 2016 and 2020. A lot of awards and achievements to her credit. I welcome Madam to chair this particular session. Can I have this?
Thank you, Sintris.
Yeah. Professor obstetrician and gynecologist from Malik Hospital at Aligarh, the president of Aligarh chapter of ISOPAB and chairperson of the Rural Health Committee of National of achievements and awards on her name. I welcome respected Professor Seema Haki, Madam, to chair this particular session. I have a very interesting session that is lined up with 3 lectures. One on importance of mental health through key reproductive phases of a woman's life, on mental health and gynecological conditions. Can I request the chairpersons to introduce the speakers? First, can I request Jyotika Desai, Madam, to introduce Dr. Prabha Chandra and welcome her for the first lecture.
Can I have the CV, please? Because the slide is blank. The slide is blank.
I think the slide is blank.
Except for the
ICOG.
Prabha Chandra doesn't need much introduction in the field of perinatal.
Jyotika, we can just start, I think. You can say what you know about me.
Speaker can introduce themselves.
However, Prabha is now the director of NIMHANS.
Exactly.
She has been in the forefront of perinatal mental health and has the unique distinction of initiating the first mother-baby unit in India. And she has been a huge pillar of support when we approached her saying we need obstetricians to be trained in perinatal mental health. She has, spearheaded and supported us all the way. So a big personal ode of thanks to her. And she's also been conferred the honorary fellowship of the RCOG for her huge body of work in perinatal mental health. So with that brief introduction, Jyotika, I think we can invite Prabha to do her talk.
Prabha, we know her from a long time since she's from Bangalore. And anybody has any mental issues, and the patients, of course, the go-to person is Prabha. So she keeps coming to our fora to give talks, and we are very fond of her, very proud of her. Prabha, can we have your talk?
Sure. Thank you so much to ICOG, to everybody who has been here, Madam Sheila Mane, and also Jyotika. First of all, I want to really appreciate the association, close association we've had with obstetricians and gynecologists. I know that in Bangalore, the obstetrician team is very closely linked to mental health. We keep every program that they do, they have a talk on mental health. And in fact, the Chennai psychiatrists were very envious. They were asking me, how do you manage to have such a close liaison with obstetrician and gynecologist? So I said, now we have Umaram in Chennai to do all this liaison work. But it's been such a journey for us because I think both these conditions are extremely closely linked. So in the next 5 minutes, I'm going to basically introduce why should we be doing this course, what is the importance. And like others said, I think we have extended this course now to a bit more than what we had. The earlier one was only perinatal mental health. And now we're talking about the interface between reproductive health, gynecological conditions, and women's mental health. We all know that women's mental health is deeply intertwined, not only with reproductive events such as pregnancy and menopause, but also with other chronic gynecological conditions, and particularly in recent years with infertility. And these mental health conditions often go unrecognized, undertreated, or indeed normalized. Now, the interface of these two conditions is shaped by 3 interacting forces. The first, of course, is biology. We know that hormones have a great influence on the brain. Particularly, estrogen and progesterone affect serotonin, dopamine, and many stress pathways. So that's one way in which biology is linked to mental health.
Sorry for interrupting, ma'am. Do you want to share your screen, please?
No, I'm just doing a talk right now. I will.
All right. Okay.
I'll be doing my regular talk later. So I'm just introducing the whole topic to you.
Please.
Yeah. The other important thing is about pain. So we know that many conditions in gynecology, particularly endometriosis, or even pain related to reproductive health conditions, perinatal conditions, can influence mental health. And we know that pain and depression have a very strong relationship with each other. So that is another biological reason why you might have problems. And then, of course, the third biological reason is inflammation. More and more literature on how immune mechanisms, which are common to many gynecological conditions, also are common to mental health conditions. A few examples are, more literature is coming in, particularly related to endometriosis, to PCOS, and how immune mechanisms, particularly in endometriosis, share a strong relationship to the same immune parameters which are affecting brain. And we know now with studies that conditions like depression and anxiety are also maybe immune mediated. So just to kind of summarize, biologically, many conditions are related to mental health problems, hormones, pain, and inflammation. The second, of course, is psychological. We know that, several reproductive health issues, particularly fertility, becoming a mother, pregnancy, postpartum period, are all linked closely to identity, to distress, and severe anxiety related to the pregnancy itself. So psychological conditions, and then more social contexts of stigma, and we'll talk about it a little over the next 3 days about how stigma, gender roles, violence, access to care also influence the interface between reproductive health and gynecological conditions. So what I want to emphasize here is that our two specialties are really very closely linked. And it's very important for psychiatrists to know about reproductive health and gynecological conditions. And it's very important for OB-GYNs to also know about mental health. And if we want to give a woman a truly comprehensive care, then we really need to do this. The other thing I want to emphasize, and that you'll see in the next few days discussions, is the need to have a life course approach. So across a woman's life, adolescence is one period, the reproductive years are another period, and of course the perimenopause and the menopause. So anything that we do and consider should be looking at it in terms of life course. Menarche is a big important event, and we know that there are several menstrual disorder related conditions and emerging conditions which happen in adolescence. We also know that the adolescence is one of the most vulnerable times for mental health problems also, as we can see in the world today. The maximum problems are happening in the youth. And this is also linked very closely to reproductive health. Just to give you an example, once a girl becomes 12 years, once she has puberty, usually in that pubertal age group, the rates of depression becomes 4 times that of boys as soon as puberty starts. Now, clearly, it's linked to the hormonal changes which are happening, and of course some social issues like body image. So again, need to pay attention. Reproductive years, we all have been working in perinatal mental health together, particularly Dr. Jyotika and I, and Dr. Uma Ram and I, myself, we have had lots of cross-referrals of cases. We know that the postpartum period in a woman's life is probably the most vulnerable time that she can develop a mental health problem. And that's something that we recognize. Like this, the period after a baby is born till the 6 months postpartum. So the postpartum has a slightly different definition in relation to mental health. While more gynecological obstetric definition is 6 weeks, we consider it as 6 months, because the 6 months postpartum seems to be a very high risk period for mental health problems. The importance of pregnancy is being recognized only recently with emergence of the DOHA, Developmental Origins of Health and Disease, as a concept, where we realize that the mother's mental health in pregnancy seems to clearly link to pregnancy outcomes like preterm birth or low birth weight, but also in terms of fetal programming has a strong impact on the fetus, both the physical health, but also the mental, the brain development of the fetus. So again, while earlier we were focusing much more on the postpartum period, and if you ask somebody about perinatal mental health, the traditional answer will be postpartum depression. But we now know that it's much, much more than that. We are talking about pregnancy-related problems, anxiety, severe stress, bereavement in pregnancy, facing violence in pregnancy. All these conditions actually impact not just the mother, but the fetus. We are also looking at childbirth-related trauma. We know that for many women, the labor and childbirth is not a very easy experience, or even pregnancy is not a very easy experience. We also know the problems related to pregnancy loss and miscarriage, as well as fetal loss, and how that impacts the subsequent pregnancy. So all of these issues are going to be discussed in great detail. And finally, the attention which we need to pay to perimenopause, which we will be discussing today. So at each step, the mental health and gynecological problems will interact with each other. And some women seem to be more vulnerable to this. So we know that, all women go through these life changes, but only some women develop mental health problems. And I think the answer is still not very clear, but we are looking at possible genetic causes, immune responses, the role of autoimmune conditions, to explain why some women are much more prone to some of these mental health problems as part of their sort of what we call normal reproductive life. Perimenstrual mood disturbances, perinatal depression, as well as menopausal mood changes. And we will see that for some women, it appears that estrogen withdrawal itself or presence of hormones seems to be a trigger for many of these. So if you have women who've had oral contraceptive related mood changes, or mood changes related to any drugs like clomiphene, you will find that these are women who then subsequently show perimenstrual mood disturbances, as well as postpartum depression, as well as menopausal mood changes. So it seems that there is a subset of women who seem to be much more vulnerable than others. Of course, the role of childbirth trauma is also something that we often discuss, and again, it is something that is going to come up. Some conditions which, are very painful, like endometriosis and chronic pelvic pain, it's not just about the pain. We also know it's about fertility issues, sexual dysfunction, as well as, dealing with a chronic condition about which not much is known. So usually women with endometriosis are diagnosed late, suffer, and there is a strong relationship to depression and anxiety, and they interact with each other. So women who are depressed and have endometriosis often also have more pain, and the other way around. We will be talking a little bit about sexual problems, particularly those that affect fertility, such as dyspareunia and vaginismus. And again, it's linked to anxiety and relationship difficulties, as well as trauma. So again, you can see there seems to be a strong relationship. So I think the important thing to remember is that the relationship is two-way, and that there may be cycles of physical and psychological suffering, and the whole social context in which all of this happens. So sometimes what happens is psychiatrists may not understand the problem. So while many of us who are in the course today as faculty are experts in this area, it's quite possible that you might find people who don't have enough information. So we have actually created a directory of persons who, psychiatrists and psychologists who are trained in perinatal and reproductive mental health. In fact, reproductive psychiatry is now a specialty, and there are courses available. NIMHANS actually runs a certificate course on perinatal mental health, and we are planning to move to a course in reproductive mental health. And hence, training is very important, a bilateral training, I think. Listening to, because when we as psychiatrists or psychologists, look at these conditions, we tend to look at it only from our perspective. It's, I think, very important to have a multidisciplinary approach, which is what we are trying to do in this course. So, for us, this is a very exciting course. I've just given you an overview of why it is important, what all we need to study, the breadth and the length of the course, and also to say why liaison is very important. I think one of the things we've realized, and people in the audience who have worked closely with any of us will know that calling up the obstetrician or calling up the psychiatrist and saying, I'm sending this person to you, or writing a note with more details helps not only both of us to work together, both our teams to work together, but also makes the patient feel that they're not being shunted from one place to another. One of the common problems that obstetricians and gynecologists say to me is that patients don't like to go to a psychiatrist. They feel that they're being labeled. But I think it also depends on how we approach. And I know that our dear chairperson here, Dr. Jyotika, is a very sensitive, gynecologist, and she always explains to the patient why the referral is happening. And I think those are some of the things that we also need to discuss: how to liaise well with each other, how to trust each other. And I hope that through this course, we are going to gain so much from each other and learn so much from each other. So I'm going to now hand it over back to the chairpersons to continue the course. Thank you so much.
Thank you.
Jyotika?
Thank you, Prabha, for giving such a brief but intense overview of where all we can face problems, mental health issues from childhood, adolescence till the menopause. You were talking about endometriosis being a issue which is coming up. I would rather think of menopause. I see so many menopausal women, in midlife and post-menopause, who are suffering from depression, and it is not taken cognizance of. So I think at all stages of life, we need to be careful, and healthcare providers like us have to be more aware of what changes can be seen and how we can pick them up fast so that these people don't go from pillar to post trying to find solutions to their problems. That was very nicely said, Prabha. Thank you. What about, are you going to talk now or are you going to?
No, Dr. Ashlesha will do the next section.
Fine. I hope, Dr. Seema, would you like to introduce Dr. Ashlesha if her CV is there?
Definitely, if I get the CV, I would love to introduce her.
It's okay. I can. Thank you so much for having me. I think most of our speakers have just said we'll introduce ourselves. I'm Dr. Ashlesha.
Yeah. Please.
Yeah. Thank you. I'm Dr. Ashlesha Bagadia. I essentially am based out of Bangalore, and I'm a perinatal psychiatrist. I am a co-founder of a community mental health team called Green Oak Initiative. And like Dr. Prabha said, we work quite closely with obstetricians in Bangalore and quite a few obstetricians in other cities as well. Now, because of online, there are many patients consulting online as well. So I'm very glad to be here. And I've been very lucky to have been part of this training program from the beginning. And we've seen it grow, and especially seeing the commitment of all the other obstetricians in the training, and very excited to see such a large group today and such a big interest. So I will get started without further ado. I'm going to talk about screening in obstetric and gynecology practice, and why is that important, and what are the ways in which we can screen. Is it okay for me to get started?
Yeah, please.
Yeah.
Sure, go ahead.
So, sorry, just a minute. Let me just. Can you see my slides?
Can you
Yes, ma'am. Yes, ma'am.
So please.
So, one of the commonest things that many obstetricians tell us is they don't have really the time, even if they wanted to spend a lot of time in addressing mental health issues. But so we are hoping that today this talk really helps you to look at some key things that you can do even if you have a busy OPD. And Dr. Prabha has really highlighted why we need to work together. But what I want to highlight is also why screening is important. So in the perinatal period, we know now that mental health issues are very high, almost as high as, say, diabetes and other lifestyle conditions that we commonly screen for. The suicide risk has also gone up in mothers, both antenatally and postnatally, especially. And definitely there is an impact on the fetus if there is an unresolved or untreated mental health condition. What we also know in terms of gynecological conditions, just like Dr. Prabha highlighted, is that if the mental health aspect is not sufficiently addressed, the outcome is not as optimum. The prognosis is poorer if we are only addressing the, say, hormonal imbalance, diet, and lifestyle, especially because of conditions like PMDD, perimenopause. We know that majority of the treatment options are, changes in lifestyle. But if there is an underlying mental health issue, then it has an impact and the prognosis can be affected. Another biggest problem we face with mental health patients or people with any mental health issues is that there is a reluctance perhaps in the clinician. And I'm not only talking about obstetricians. We know this reluctance is there even in mental health professionals to go the extra length. So there's a reluctance to ask because of stigma. There may also be lack of awareness in health professionals. But the commonest one that many obstetricians tell us is that, okay, we'll screen and we might find something. And then what do? We don't really know enough professionals or psychiatrists or psychologists who can deal with these issues. So lack of resources is a big problem, especially in smaller, remote parts of our country. So what we do know from our patients and some studies that have also come out of NIMHANS is that if we don't ask, they are very unlikely to reveal on their own. Unless they are actively, significantly, very obviously unwell and thought disordered or maybe psychotic, if they're just suffering quietly with anxiety and depression, they are not likely to reveal on their own. But also, what we know that if a woman is generally healthy physically, she may only end up seeing her obstetrician, gynecologist during her lifespan. And so that might be the only doctor. So you are perhaps at the best position to do the screening because you might be the only point of contact for the women who, even under normal circumstances. So they are likely to come to you for contraception. They're likely to come to you for, say, hot flushes. Definitely likely to come to you for pregnancy. So even if they don't have any illness issues related to obstetric or gynecological conditions, they're more likely to come to you just for screening, just for routine checkups. So you are really at the optimum place to do the screening, and they are also more likely to open up to you. They may, we know that even coming to see a psychiatrist is, there is reluctance. But if they come also, there is less likelihood for them to open up unless they have had some reassurance from the obstetrician. And in our setup, at least in India, we know that many times obstetricians are almost like the default general practitioners for many women. They are likely to only go to the obstetrician for everything, and then they might get redirected to other things. So there are multiple reasons why we need to screen, because you are really at the crucial stage. And what you are also likely to do is likely to do preventative care, and you are at the right place to eh, pick up before it gets to a point of no return, or before the risks start outweighing the benefits of treatment. So one of the difficulties that we do have in terms of, let's say, perinatal screening systems. So I'm covering all aspects, not just pregnancy and postpartum, but especially for pregnancy and postpartum. We know that there are existing screening systems. So there is something called as Edinburgh Postnatal Depression Scale, which many of you may be familiar with. It's a 10-item questionnaire developed in 1987 by Cox and his team. It's definitely widely used. It's also actually established in sort of computerized systems in routine healthcare in most countries. But I'll talk a little bit about the problems that can arise with these screening systems. Now in UK, there is a 2-item questionnaire called Woolley question, which are simple 2 questions that can be implemented by anybody. And it really asks 2 questions. Over the past month, have you been bothered by feeling down, depressed, or hopeless? So sort of covering most of the symptoms that come under depression, feeling down, feeling low, feeling like nothing's going to work. And that is the internal system. And then the next question is, over the past month, have you been bothered by having little interest or pleasure in doing things? So as a result of feeling down, are you then not able to do anything that you get joy out of? So what they found with Uli two-item questionnaire is this was the most sort of sensitive in picking up maybe the possibility of underlying mental health conditions. So these are the commonest ones that are used in pregnancy and postpartum. But the guidelines that recommend for mental health conditions in any sort of stages of reproductive life cycle is the generalized anxiety disorder, the modified version. So again, the GAD has a two-item questionnaire which is very easy to implement. You just ask, this is the anxiety questionnaire. So if you're worried about anxiety, then you just ask, have you been in the last 2 weeks, have you been bothered by feeling nervous, anxious, or feeling on edge? Not at all, several days, or more than half the day. So you're just getting an overview of this has been happening a lot in the last 2 weeks. And one is that it's been happening, the other is they're not able to stop it. So you're sort of this two-item questionnaire can get you an overview. Okay, there is a problem. Let me ask more. A common thing an important thing to really address, which is again, like I said, even mental health professionals sometimes can shy away from, is asking about self-harm or suicide. And with the current lifestyle, and especially with adolescents, the kind of social media exposure they are getting, self-harm seems to have become a lot more common, and even if it is non-suicidal self-harm. And if there is self-harm, then invariably there is an underlying mental health issue, which invariably might affect their treatment and outcome of the physical reason why they're there. So a common opening kind of questions can be, do you have any thoughts of hurting yourself? And one of the ways in which we tend to ask, which could be a way to ask, is if you have had any thoughts, what is the closest you come to doing something? Have you made any plans? And it's good to start a little bit gently with just asking about thoughts and then moving to plans, rather than starting off by saying, are you suicidal? Do you want to end your life? And even if sometimes that they're just relieved that you're asking them, someone is asking them, they might back off if they feel that there is a judgment coming. So you just be a little bit careful of making the question a little bit more curious. I really wondering whether you're talking about so much stress. Have you come close to doing anything? Of course, we also want to know, in the recent past, have they hurt themselves? And if you're seeing them in the pregnancy or postnatal, especially immediate postnatal, do you have any thoughts of harming your baby? Now, this question, again, it's important to normalize a little bit, because more women than we know actually have thoughts of either not necessarily just harming, but just being resentful about the baby, wishing that the baby was not there. And that sometimes can result in thoughts of harming the baby, but that doesn't mean that they're going to act on them. So it's really important to ask these questions in as gentle and normalized manner as possible. And if any of these are flagged, then it's important to then think of referral pathways. And I'll talk briefly about referring as well. So coming back to the screening tools that I was talking about, now the reason why I'm telling you about these two-item questions, is because some of the long established screening tools, especially things like EPDS, are not easily adaptable to the Indian clinical setting. They are validated in many Indian languages, and they have a good validation for research purposes. But on a day-to-day basis, when you want to use it, the difficulties we have is that the questions can be quite ambiguous and not very easy to sort of adapt to our things. So if you ask a question like, I've been able to laugh and see the funny side of things. So it's not very easy. I mean, in English, we seem to get it. But if you think about asking this in, say, Kannada or Hindi, it's not that easy. And it just doesn't lend itself to giving a good answer. Things have been getting on top of me. I've been so unhappy, I've had trouble sleeping. So these are the items that have been found not to have good sort of language conversion. And definitely what has been established in published articles is that there are high rates of false positives, high variability between interviewers. So what they found, especially when they studied this screening tool in other South Asian countries, especially like in Vietnam, Malawi, and other language countries like in South Africa, in Ethiopia, that the cutoff scores needed to be a lot lower for for them to pick up mental health conditions. So almost sort of taking away the benefit of administering a long screening tool. And also these, especially EPDS, didn't really pick up a mental health condition like anxiety or depression, but it was picking up transient distress, right? So NIMHANS developed a self-administering screening tool. And what we found that even if you don't administer a tool, if you focus on risk factors, when you're seeing your patients, if you look at, what are the risk factors that actually lead to difficulty in mental health for, say, pregnancy, antenatal period, postnatal period. And the risk factors that we know are is if the pregnancy is in a young age, if the literacy level is low, if there's lack of social support, financial stress, emotional abuse, domestic violence. So these psychosocial risk factors, even in your non-pregnant women, definitely add the risk of them developing or already having a mental health condition. And we know past history of any mental health condition is definitely likely to lead them in developing something when their hormones are getting affected. Just as Dr. Prabha mentioned in the introduction, that any past history, so you could ask for past history of, say, premenstrual difficulties, which can give you an indication that this person is more likely to have some difficulties during the postnatal period. And definitely current history of any changes to their mood, to their anxiety levels, to their stress levels, if they're constantly feeling overwhelmed. And if you're able to keep the response, like find out, just are you having this all the time or sometimes, that can give you an idea of how to, whether this is something that is just there as a transient thing or it's going on for a long time. And in this questionnaire, we'll be sharing these resources with you all after the course. In this questionnaire, we also have like a single red flag questionnaire. If you question, which is suicide, if that is there, even if other questions haven't elicited a response, then if this is there, that's enough to do a referral. Also, you can ask them, do you want to see someone, a counselor or someone who can help you address your mental health issues? And nowadays, especially with young people, they are more opening up to being, open to a referral. And so even if they don't meet any criteria, if you are worried and you ask them, do you want to see a mental health professional? And if they are willing to, then that can be a good ground for referring. So some of the ways in which, and I think this is just a very small list, and I'm sure, with all the senior obstetricians here, you must have your own set of questions that you like to ask. Some of the open-ended questions are, things like, I see many pregnant women. I always check their mood. You've had a lot of difficulties around your periods. Are you getting overwhelmed about it? Would you like to talk more? So a lot of these open-ended screening questions can be very helpful. One of the thing is really important is, when do you want to ask these questions? And I won't go into details of this, but what I want you to just think about is any contact during pregnancy, during their periods, premenstrual stage or menopause. Even if you see them once, it's important to just make sure you elicit if there is any history of mental illness, because that will give you a starting point and a ground to get started. One of the other things also to remember is you're going to do screening tools. You may ask these questions, but sometimes you may not have the time. So you could just look at how are they appearing and behaving in their way of their body language, their dress, any unusual features are there. Are they talking very fast? Are they sounding incoherent? And you could then ask them about how they're feeling. But if you notice a change, sudden change in their behavior, that also can suggest that you maybe need to follow them up, monitor them. And so sometimes you may not get a chance to ask screening questions, but you may have some doubts. So you may monitor them a little bit closely. There is a talk later on psychiatric emergencies where we'll talk a little bit about how to act quickly when you're worried about something. I like to end my talk with just this, that just remember, sometimes there are red flags that can help you. Recent or rapidly changing mental state, if the new symptoms are suddenly emerging, if there are psychotic symptoms that actually involve infant, in the perinatal period, in the postnatal period, what thoughts of violent self-harm, previous acts of violent self-harm, and if there is a deterioration in functioning, especially if their care of the infant has got affected, if their sort of vegetative symptoms are affected, not eating, not at all sleeping, severe insomnia, and routine little bit of reassurance that you do and the kind of engagement you have with them just doesn't seem to be working. So these are the red flags, and I won't go into details. I'm mindful of the time. But anything that is high risk, you consider that as a low risk threshold to refer. And if you have no time, like I've run out of time for my talk, but if you have lack of time, at least ask this. Ask about past history of mental illness, anxiety, depression, or psychosis, of trauma, perinatal loss, psychotropic medication in the past. Past history is the best predictor of future illness, and check for red flags. Another important thing is train your team to flag these questions as well. Sometimes they become more chatty with the nurses while they're in the waiting room. So if they get trained to pick up some red flags, that can be very helpful. So in summary, anytime during the contact, please ask screening questions. They can be clubbed with education. Try and get to see them at least alone for one time during your sessions, and include key family members in the screening. So with that, I'll stop my talk. Thank you very much.
Seema ma'am, over to you for your comments.
Yeah, that was an excellent talk. And this topic is very close to my heart also, because if somebody is suffering from a mental illness, especially depression, their pain is so much that it is more than if somebody loses a limb with upper limb or lower limb, or even a major distortion of the face and all those things after accident. That pain will be lesser than the pain a person suffers when the person is depressed. Being a doctor, especially obstetrician and gynecologist, we see these problems quite often. And especially the mental issue, when they are there in a female, it is going to affect the baby also. For male, if they have a bipolar disorder and they are on medication and they are well managed, it's okay. With the female who is a bipolar disorder and is on medication, the medicines which she is getting is going to affect the child. So for them, like whether they should produce a child or not, that issue is also of a major concern. When we were students, this psychiatric part was quite a neglected one. But these days, more and more awareness, and everyone is encouraged to speak about their psychological problem. And now it is considered as taboo, but not as much as when it used to be there years ago. So the topic was really good, and your questions, simple questions of asking, how do you feel in everyday life, or do you enjoy doing the work which you do, or do you get pleasure of the activity which used to be very close to your heart? All these questions are definitely going to tell us if the female is suffering from mental disorder or not, and it should be adequately addressed. And as Dr. Jyotika has made a team and sending the patient, we are also doing the same thing, calling the psychiatrist, telling them that this is the problem my patient is suffering from. And then and you have to develop a rapport with the patient. Otherwise, they don't cooperate. They think that unnecessarily we are sending them, and they will be putting on medication which will make them sleep all the time. So all these factors should be addressed, and I'm very happy to hear Dr. Prabha and Dr. Ashlesha, and that has definitely increased our knowledge about mental illness in
Thank you, Seema ma'am. So we go on to our next presenter now. It is again Dr. Prabha Chandra ma'am. She will be discussing mental health in gynae conditions. So madam has already been introduced. So Prabha ma'am, over to you for your formal presentation, ma'am. Welcome once again. Prabha ma'am, are you there? You're muted, Prabha.
Yeah, can I share my slides?
Yes, ma'am.
You have to make me host.
Backend team, please make ma'am co-host so that she can make her presentation.
Yes, ma'am. Yes.
Thank you, Poonam.
Done, ma'am.
Thank you. Okay, so Jyotika, as per request, I'm going to talk about menopause.
Prabha ma'am, you are put us on a presenter mode because we can see both your slides. Can you please edit that?
Can you do it full screen, ma'am? For
Thank you,
benefit
ma'am.
of audience. Yeah. Yeah, that will be good.
Is that okay?
Not yet.
Not yet, ma'am.
Not yet.
Yeah.
My opinion has been asked.
On display setting, there will be the option of full screen.
Yeah, I'm doing that, but for some reason it is not happening.
Okay, ma'am, you can go on like this only.
Continue, Prabha. It's okay.
Yeah, I'll just continue. Yeah, so basically I'm going to be talking. So we had some discussion around, what is most relevant in terms of gynecological conditions. And Uma and I thought that we will discuss menopause, and we will also discuss what happens when women who are on psychiatric medications develop menstrual irregularity, because these are two things which I think are important and are not adequately discussed, especially the latter is not adequately discussed with obstetricians. So when you look at mental health in menopause, you're basically looking at, 6 important blocks. So one is, of course, the vasomotor symptoms, which most of gynecologists treat. They rarely come to a mental health professional for that. The second is cognitive symptoms, which basically means women say that they have brain fog, they are not able to pay attention, they can't concentrate. Then is sleep problems, particularly insomnia, very often complicated by vasomotor symptoms. Sexual problems, decreased libido, as well as dryness of the vagina and pain. Depression, most common, and we'll talk about that a little bit in detail. But also the important thing to remember that severe mental illness like schizophrenia and bipolar can actually worsen during menopause. And that is something that even many psychiatrists are not aware. So even when we take history, sometimes we find that people have not asked about perimenopause, about the fact whether, periods are becoming irregular. So it's something that we need to be very aware of. So why am I discussing vasomotor symptoms? I think I'll just have some water. That's what happens when you become a director of an institute. All you're doing is talking since morning. So it's been seen that women who have vasomotor symptoms also have higher problems related to mental health. And I think that is something we must remember, because many of them have anxiety sensitivity. Many of them have sleep disturbance because of vasomotor problems. And if you're not sleeping properly, in the morning, your brain is not working properly, you're not very relaxed, and there is worsening of depression. So I think this is something we need to remember. I want to particularly talk about cognitive symptoms. Many of us in this audience have probably gone through perimenopause and menopause. And we know that one of the things that happen quite often is that we feel often that for some reason my brain is not working as it should. I'm not as sharp as I should be. I'm not as quick as I should be. I'm having a brain fog. And when you do like an objective testing, you find that there are actually no problems. There's no memory problems. There's no concentration problem if you do a testing. But subjectively, you feel that the brain is not working. And there is a biological reason for this. In fact, there's been a lot of correlation between memory problems and vasomotor symptoms also. Then we come to sexual symptoms. Again, a lot of reluctance to report because it's accepted as normal at this age. There's a lot of embarrassment related to it. Dismissal by health professionals, often saying, you know, you're growing old. Why do you need to talk about it? Why do you need to discuss it? And you can have what is called hypoactive sexual desire. That is, you have a decreased desire. There's absence of sexual fantasies or thoughts, decreased desire that causes personal distress, or it could be because of genitourinary symptoms, because of vaginal dryness, dyspareunia, urinary frequency. Many women develop incontinence at this time, so there's embarrassment because you feel you're not clean, you're smelling. So all of this actually leads to sexual problems, which again can cause relationship issues, can cause depression. The other important thing that we discussed was about depression in the menopause. What we need to know, this is a study which has been done in India, where the prevalence of peri and postmenopausal depressive symptoms was quite high. I mean, about 40% of women reported some symptoms and 26% felt that they actually needed help. Depressive symptoms in the menopausal transition are of higher severity than before or after menopause. So when a woman develops depression in the transition, it appears that the severity is much higher than what you expect previously. Like I mentioned, vasomotor symptoms are high. Suicide rates in the US seem to be the highest. Not in our country. In our country, it's the perinatal age group, early reproductive age group. But in the US, the highest rates are between 45 and 64 years. Sometimes it can be difficult to diagnose as menopause related. Many times my students in the clinic actually miss depression related to menopause because they will say, ma'am, that the woman is having her periods, and they don't recognize that physical symptoms can often be, very subtle, and you actually need to ask. The symptoms of depression, Dr. Ashlesha talked about the symptoms of depression. Some things in menopause seem to be very different from what you see in the rest of the time when you get depression. Paranoid thinking, I'm going to talk about this a little. Feeling very self-referential in some way. Feeling that people are talking about me, people are intentionally trying to hurt me. This seems to be a symptom which comes in menopausal depression, which you don't find earlier. So it's not like a psychosis or anything like that, but just feeling very, very more self-referential. Irritability, again, a mood symptom, much higher in menopausal depression than in other forms of depression. A lot of tiredness, which can be there, and low energy levels. And we did talk about the other areas. So I think it's very important for us to understand that what are the predisposing hormonal factors. So like I mentioned earlier, that if a woman has had history of premenstrual dysphoric disorder, which we will be discussing, the chances of developing menopausal depression seem to be high. If there is depressive response to hormonal contraceptives, again, there seems to be a propensity. So I think when we're taking history, it's important to ask, have you had a past history of depression? Have you been treated for depression? Sometimes women will not share. So you can ask them, have you ever had counseling or any? They prefer to say that they've gone through counseling rather than saying they've gone to a psychiatrist. History of depressive response to hormonal fertility treatment, severe vasomotor symptom, and any use of prolactin elevating medications. So we'll talk about this a little later in our presentation about what prolactin elevation medications can do. Past mental health problems, especially depression. Excessive alcohol use. I'm saying this now because we're getting more and more women who are dealing with depression through alcohol or sleeping pills. And I think we must recognize that this is a growing problem and always ask. Somehow in our clinics, we seldom check for alcohol use among women, but we know that alcohol use escalates suddenly in women. Unlike men who keep drinking for a long time and then develop alcohol dependence, women develop alcohol dependence very rapidly. And many of them will just be, having small quantities, and suddenly they develop symptoms of being craving and developing addiction. Poor physical health is another perpetuating factor for depression. So if a woman has arthritis, if a woman has other autoimmune conditions, which also get exacerbated during this period, uncontrolled diabetes mellitus, all of that around the menopausal transition will increase the chances of depression and a high burden of care for others. This is also a time when women are sometimes looking after their parents who are unwell. They're also looking after adolescent or growing children, and hence the high burden of care can also be a risk factor. And that's something we should remember. This is a questionnaire which is called MENO-D, and it's a very important tool, and we will share this with all of you as a resource later. The reason is because the kind of problems that the kind of tools for depression which you normally use may not be able to identify depression in the perimenopause. So, like I said, low energy. Women will say that I sleep at night, but I feel very exhausted. I mentioned about paranoid thinking. This is of a different quality from the usual, and it says, the women will think, I'm hopeless at my job and they're all talking about me. I'm sure they're sort of criticizing me. My husband seems to not care for me any longer, or he's talking to others about how useless I've become. So it's a very, and it's a lot of it is related to one's own self-esteem, and it's not uncommon to have this. Irritability. Now, this is called a depressive equivalent symptom. So when instead of being sad, the woman gets snappy, and women will actually tell, or the partner will tell that you're becoming very snappy, that you're, getting irritated for the smallest things, verbal outbursts about minor incidents, sometimes even rage responses. And when you ask women, they will tell you that, I was driving and normally I will not yell and scream like this, but, a small thing made me just lose it. And I think that is something which will actually, and women often find it very comforting that somebody is actually saying that it is something related to menopause. There is a reason for it. Otherwise, they think we're just going crazy. Why am I doing this? I was not like this earlier. So I think these are things that we need to ask. Decrease self-esteem. So as you grow older, when you're in your late 40s, 50s, many times, even at our workplace, we'll find that younger women are taking over, that, newer techniques are coming, you're not very abreast with it. And as it is and you're putting on weight, your hair was not like what it was. So there are many reasons why women often have self-esteem issues around this period. And this is another feature. If it continues, then we have to think whether the woman is depressed, feeling isolated, even feeling like you're in a bubble, even when you're with other people. It's some way that you feel kind of, distant from people. You're there in a crowd, but you're like, I'm not relating to them. So feeling like you're in a bubble. Heightened anxiety. And this is a very common symptom which we often ignore. Feeling anxious. Things that I normally gave a talk very easily, but for some reason, even a small 10-minute talk, a webinar is giving me a lot of anxiety. So, asking about anxiety, headaches, muscle and joint pains, sleep disturbance, like we said, and, difficulty returning to sleep, weight gain, which we know that can happen, decreased libido, impaired memory, and problems concentration. So, in fact, they may even say, I find it hard to watch TV and, follow a storyline. Women will often tell you that I used to be able to tell the whole story, and now I'm watching something on Netflix, my brain is totally zonked out. So I think these are the kind of symptoms that actually menopausal women will tell you. And as you can see, these symptoms are kind of different from what you normally get in depression. So a questionnaire like MENO-D actually helps. Insomnia is a huge problem. And one of the reasons is that estrogen, progesterone modulates sleep, and they're also protective for obstetric sleep apnea. So, and there are melatonin changes in the brain. So all of this, like I mentioned in my introductory talk, the brain is also changing alongside what is happening. So insomnia can be due to many reasons. In fact, some women will tell you that my husband is complaining that after menopausal transition, I'm snoring, something that I never did earlier. And these are indicative of problems related to sleep. And the problems related to sleep could be because of vasomotor symptoms, because of OSA, because of psychosocial factors, because of depression and anxiety, because of RLS, restless leg syndrome also starts around this time. So I think it's important for us when we are asking for assessing sleep problems to kind of have a holistic point of view. So diagnosing menopausal depression requires that we understand that the symptoms may fluctuate. They may be a bit resistant to antidepressants, and brain fog is a very common symptom. I mentioned about schizophrenia and bipolar disorder. So after 45 years, there's a higher risk of relapse in women on treatment with schizophrenia. So we know that estrogen is an anti-dopaminergic hormone. So as estrogen comes down, dopamine will go up. And when dopamine goes up, psychotic symptoms increase. So we often find that women on with schizophrenia who are on antipsychotic treatment, maintaining super well for 10 years, around 45, 46, they will come with a worsening of symptoms. And invariably, it is related to perimenopause. And if you do an FSH, you'll actually realize that estrogen is falling, FSH is increasing. It's indicating of perimenopause. As a result, they may require higher doses of medication. And there can also be worsening of symptoms. What has also been seen that women with pre-existing schizophrenia or bipolar disorder are more likely to experience early menopause and may have more severe frequent menopausal symptoms. So having discussed all this, so what I've discussed till now is the whole range of psychological problems that you can get. Commonest is depression, but there's also sleep problems, vasomotor symptoms, cognitive thinking related symptoms, feeling paranoid, and of course, sexual problems. That I've discussed that the kind of depression you get is slightly similar, slightly different from what you get in other forms of depression, with irritability, anger, and paranoid thinking and low self-esteem being much higher than what you normally get. Now let's look at how do you manage it. So I think it's very important for us to have a multidisciplinary team. So you have the gynecologist. If there's a physician, you need the physician, you need a psychiatrist, and you need a psychologist. Every time I have managed somebody with menopause, perimenopause or menopause, I've always liaised very closely with the gynecologist, because if we are thinking of starting hormonal treatments, we need a very close liaison. So a multidisciplinary team approach. What is important is in terms of medication, there are few RCTs, but some antidepressants like desvenlafaxine and agomelatine. These are two of the newer antidepressants which have been shown to be effective in perimenopause. Menopausal hormonal therapy is now considered first line for perimenopausal depression. And this is particularly true if women have vasomotor symptoms and if they have symptoms of menopausal depression, and if there are sleep problems. So menopausal hormonal therapy is considered now first line. You don't have to wait. The important thing is to start early, personalized therapy, of course, careful patient selection, which all of you do, and a low or an ultra low dose rather than the full dose of treatment. First line, if you want to start menopausal hormonal therapy for depression, mood neutral OCs are preferred. Tibolone is one drug which has been used, and there are 4 trials which have found it useful. However, you may want to use estradiol patches with oral progesterone, combine menopausal hormonal therapy, and this is something that I often do, plus antidepressants, or combine menopausal hormonal therapy with neuromodulation. Neuromodulation is a very important form of treatment in psychiatry now, where we give transcranial magnetic stimulation, which is very safe and quite preferred by patients. So these are treatments that we can actually start. For vasomotor symptoms, actually, antidepressants are very useful, particularly drugs like venlafaxine, desvenlafaxine, and paroxetine have a very good evidence. But psychotherapy also helps. And that's why I've said that a psychologist being there is important. If we are treating insomnia, it's important to address the primary cause of insomnia, which could be depression and anxiety. But insomnia can also be treated by antidepressants. So the take-home messages are: recognize that menopause affects the brain and hence mood and the course of psychiatric disorders. Careful use of hormonal therapies in perimenopause and in premature ovarian insufficiency within 10 years of menopause alone or in combination may help mood a lot, and that psychiatrists and gynecologists should work together and be aware of the side effects. Now I want to move on to a little bit about the second part of my presentation, and that is about let me see.
It's visible, ma'am.
Visible? Okay.
Yeah.
About psychotropic drugs and menstrual irregularity. So when we're talking about psychotropic drugs and menstrual irregularity, the types of menstrual disturbances you can have is amenorrhea, oligomenorrhea, any of these can be there. But what is important for us to understand is two major classes of drugs we need to know which cause problems. One is antipsychotics, particularly these antipsychotics. If a woman is on risperidone, amisulpiride, or some of the typical antipsychotics, these are drugs which are very highly dopamine blockade and will increase the prolactin. Many times and prolactin, of course, we know that suppresses GnRH, decreases LH, FSH, and causes anovulation. So many women who are taking risperidone, even 2 mg or 1 mg of risperidone for psychosis or for bipolar disorder, sometimes they may not even tell you. They may come for infertility. And when you do a prolactin, you find that it is high. They may be secretive about it. They may not have told even their partners about it or their in-laws about it. So I think it's extremely important for us to check this. I've had women who've had hyperprolactinemia with amenorrhea and galactorrhea who've gone to gynecologists and endocrinologists. Pituitary tumor has been suspected. MRIs have been done because they have not revealed to their gynecologists that they are actually taking these medications. So we must remember that any of these medications can actually increase. Some of the newer antipsychotics, and I will tell you which ones, do not cause increase in prolactin, and they are safe to use, and they can actually decrease the prolactin. So the prolactin levels, which are suggestive of drug effect, and this is very important, is typically they are less than 150 to 200 nanogram per ml. Anything more than that, you have to think of an independent cause. So if it is between this, you don't actually have to worry. And you can also ask the woman, did it start after you took the medication? If she says that she started after taking the medication, then it's clearly linked to the medication and it's not an independent cause. In fact, some drugs like olanzapine, which is again a drug which is commonly given, that causes weight gain, which may also cause menstrual irregularities, but that prolactin level will be around 100. So very important to know that alternative etiology should only be considered if it is more than 200 and not less than 200, even if a woman is on antipsychotics. So let's say a woman is on antipsychotics, she comes and tells me, ma'am, I'm having galactorrhea. I mean, this is there's milk production and I'm having amenorrhea. I do a prolactin level. I find the prolactin to be more than 200. I will suspect another cause for hyperprolactinemia. So that's the way we look at it. More than anything, they need reassurance. So women get very scared if they start having breast milk production and if they develop amenorrhea. This is particularly true in women who are not married. Their mothers or somebody will come and even the women will start thinking, have I become pregnant? Is this because of pregnancy? And there is a lot of stigma around it. So many times they don't even tell us that this is happening. So I think it's important. The other drugs, so antipsychotics are the biggest culprit. The other drug which is a culprit is valproate. So valproate is given in epilepsy. It is given in bipolar disorder. Actually now, more and more countries, including the Royal College of Psychiatrists, OB-GYNs, Europe, have actually banned valproate use in women in the reproductive age group because the side effects are enormous. So PCOS is very common. And second, that it is a very teratogenic drug. So the rates of neural tube defects are very high, whether you give folic acid or not. So routinely, we don't, put women who are in the reproductive age group on valproate. However, if let's say a woman has had a tubal ligation and she has a bipolar disorder or epilepsy, then she may be on valproate. But even then, she may develop insulin resistance and amenorrhea and irregular cycles. So we must remember this. SSRIs, the drug which is the most commonly used, fluoxetine, sertraline, escitalopram, those never cause any menstrual irregularities. Very, very rare. If at all anything, some of them, because they cause platelet dysfunction, they may cause menorrhagia, but they will never cause amenorrhea. So you don't have to worry about antidepressants. The only drugs that we have to worry about are the antipsychotics. Now, how do we manage? So if a woman has hyperprolactinemia related to medication, the first thing we do is reduce the dose. So if a woman is on 4 milligram risperidone, we will decrease it to 2. The idea is that you shouldn't stop it. I think it's very important to not stop suddenly because she may develop a relapse. So we just decrease the dose, and sometimes with just decrease in dose, women, the period will return and prolactin will come down. So it's very important to monitor prolactin. Switch to prolactin sparing agents. So there are 2 drugs. One is called aripiprazole, which is a partial dopamine agonist, bit like bromocriptine, but a partial agonist. So that we use a lot. So either we substitute it, in which case immediately the periods will start, or we augment it with low-dose aripiprazole. The other drug which we use a lot is called quetiapine, which also does not cause increase in prolactin most of the time. So these are drugs that we use. So if a woman says she's got infertility and she's on risperidone, you can actually discuss with her psychiatrist and say, can we, put her onto something which is, lower prolactin increasing drug or prolactin sparing drug, which fortunately are now available and are very, very useful. So this is something that I think gynecologists should know about. Valproate-induced menstrual irregularities, like I said, we usually avoid it completely, but weight management and treating PCOS the way you would treat it. Because again, valproate-related PCOS is because of insulin resistance. So the treatment will remain the same as PCOS. Dopamine agonists. Now, this is something which we must remember, and I would like to point out to the gynecologist, is both bromocriptine and which is the other one? Cabergoline. Both of these we use. So both bromocriptine and cabergoline can worsen psychosis. So we should not use bromocriptine and cabergoline in women who've had a past history of psychosis. And this is something we should remember because they are both dopamine agonists. So they actually increase dopamine in the brain. And when you increase dopamine in the limbic system or the prefrontal cortex, that is when psychosis happens. So they can worsen psychosis. Only use if change of antipsychotic is not possible. So let us say a woman is very well maintained with schizophrenia on risperidone. The moment you decrease it, her psychotic symptoms come back. The family is saying, no, please don't decrease risperidone because she'll fall ill. But we want her to get pregnant. We want her to have a period because it's not okay to have amenorrhea for too long because we know the problems of prolonged amenorrhea on bone, on heart, on so many other situations. So only then we use the bromocriptine or cabergoline, but not otherwise. And even then we closely monitor for worsening of psychosis. So just to give you a summary of this part of the talk, that there are some drugs which can cause menstrual irregularities, particularly hyperprolactinemia, and we need to be aware of those drugs. But we should not tell the family to stop the drugs or not be worried about it too much because there are other drugs which are available, which are equally effective. Either we can augment or we can change. And, we very often find that a woman is on risperidone and not using birth control. And she'll say no period and we change to aripiprazole. Within the next month, she'll become pregnant and come. So because the prolactin has fallen down. So it is that effective. So I think the important thing for us, again, is not to liaise rather than getting them very worried about the fact that You're not conceiving because of this drug. You are having amenorrhea because of this drug. So not to scare them, but at the same time, like I said, many women do not reveal that they are on these medications. And all they will come with is infertility and amenorrhea, and you will be trying to figure out why this is going on. So if you find a woman who is having fertility issues and the prolactin is in this range, always ask if she's taking any other medication. That will give you a hint. So this is, I would like to end here. And we are going to have a panel discussion later, case-based discussion, where we can take on some of these issues. This is my contact details. So please feel free to write to me if you want to talk to me or refer a case or generally discuss this very interesting topic. Thank you very much.
Both the talks were wonderful, Prabha. And the second one was especially helpful. Though I don't know whether any gynecologist will prescribe aripiprazole, because I'm sure none of us have heard of it, to be honest with you.
Yeah, just to know about it, that, alternatives are available. That's the idea, that, patients will panic. Gynecologists will think, oh God, she's on this medication. What should we do? Will she even conceive? To just know that there are alternatives and that women can, change the drugs and prolactin will come down. So not to panic, not to worry, that there are very good alternatives available.
And the MinoD questionnaire, I think we should start using it in all our patients. I'm sure that will help us a lot in understanding whether they have a problem or not. I think there are questions, Dr. Anita.
I think there are
Yes,
some
ma'am.
questions, chat box. So what do you want to do with that?
So if you can answer them, ma'am, in chat box, it will be great. Or we can take, Sheila, ma'am, 2 or 3
I will do
questions.
that. I will answer on chat, because
Okay.
then we can
As
go
you,
on.
that will be great, ma'am.
Everybody
Thank you
else
so
can
much.
also read it. Yeah, I'll do it.
Thank
In
you,
respect
Dr.
of
Prabha.
time.
It was excellent.
Yeah.
As Dr. Bagdia said, I think if you share with us the screening tool as well as the questionnaire, we can put it on our website,
Yes.
ICOG website, so that it will be available for all. That we will do at the end of course. Whatever teaching material we get, we can. The whole program will go, but this questionnaire is as well as the tool, I think we can share it on our website. Yeah, thank you.
Thank you, Sheila, ma'am. With your permission and Dr. Umar ma'am's permission, can we move ahead to session 2?
Yeah, please.
The session.
Please.
Yeah. Thank you, ma'am.
What
Thank you, ma'am. The respected chairperson. Thank you, chairpersons, Jyotika ma'am and Madam Seema. Thank you for your nice inputs, and thank you to all the
Thank you
speakers
very
of
much.
session 1. Yeah.
Thank you.
Now moving on to next session, Madhuri Patil ma'am was our respected chairperson for this session, but she is busy in some academic activity elsewhere, so she will not be able to join us. She has conveyed her best wishes to us. Dr. Vaishali Korde Nayak ma'am is our second worthy chairperson. She is the professor and head department of MIMER Medical College Pune, fellow maternal and fetal medicine, NUS Singapore, and she's UG and PG examiner, so many credentials in her CV. Welcome, ma'am. Over to you to introduce our next speaker, Dr. Ashlesha Bagaria, who will be, and Dr. Runa Benjamin, who will be dealing with premenstrual dysphoric disorder and related conditions. So over to you, Vaishali, ma'am. Yeah, you can introduce the speaker.
Thank you so much, madam. I would like to congratulate ICOG for having this program. It's excellent, and I have been attending the lectures. Excellent initiative, Sheila ma'am. Many congratulations. Moving on to the next session, we have a talk on PMDD and the related disorders, and for which I invite Dr. Runa Benjamin, who is FRCOG Diploma in Mental Health Care and Counseling, and she is presently consultant at Sitapati Clinic and Hospital, and she is member of ATN RCOG and SOMI and Part 3 MRCOG examiner. Madam, I welcome you. And
thank you so much.
Yeah. So
Dr. Ashlesha, yeah. Please show CV of Dr. Ashlesha also if you have. Otherwise, Runa ma'am, you can go ahead. You are going to present it?
Dr. Ashlesha will be presenting. I mean, she's sharing the slides. We'll start the discussion after.
Okay, thank you so much, ma'am. Welcome, Dr. Ashlesha. Welcome.
Thank
You have joined us across the country. So, welcome to you, ma'am. She has joined
Thank
us from Australia, I suppose.
Right now
Welcome,
I'm
ma'am.
here, yeah, in Australia. Thank you.
Okay. So Ashlesha ma'am, I think we have been hearing you past 1 hour, and the session is handed over to you. Both of you, we are waiting. We are eagerly waiting to hear from you.
Thank you.
Okay. So we'll start with a case presentation. So this is Miss AM, who's a 20-year-old girl who came to us. This was pre-COVID. Her BMI was 33. She attained menarche at age 12. She had had regular cycles till about a year ago. She said that she was bisexual. She was on the pill and was using barrier contraception as well. And she presented with irregular cycles with menorrhagia about a year's duration. Now, she was diagnosed with depression and started on antidepressants. And she said she had a lot of weight gain after starting antidepressants. And she also had a lot of GI symptoms.
Sorry. Did I move forward? Hang on.
Move, yeah.
Sorry.
Forward.
I think I pressed the. Has it stopped sharing?
We can't see the presentation.
Sorry about that. 1 second.
Yeah, right.
Yeah, this is the one. Yeah.
So she was diagnosed with a mood disorder about a year ago, and the medication that she was on was sodium valproate, clonazepam, duloxetine, lurasidone, and melatonin. She said that she had tried CBT previously and didn't feel that it helped, so she refused to see a psychologist. She was doing third year undergraduation in English in one of the city colleges, and her mother reported that she was getting into trouble with her classmates at school and her teachers at, classmates at college and teachers at college as well. She came from a single parent family, had a younger brother, and she did say that she smokes and drinks alcohol and uses recreational drugs over the weekend. So, Dr. Ashlesha, how would you go about examining this lady? What would we include in the examination?
Yeah, thank you, Dr. Runa. So this person clearly comes to you already having a mood disorder. One of the initial things, you need not do a screening questionnaire, but what will be helpful to know is this mood disorder, whether it's depression, anxiety, bipolar, whatever it may be, is it adequately treated? Because it looks like despite being on several different medications, she's not adequately treated, and that can give you an idea of how much of an impact it must be having on her premenstrual symptoms. Now, in terms of with her, what we would want to know, especially if she's coming to you with difficulties, is the duration of her mental health symptoms, are they present all the time, consistently throughout the month, with the same intensity? And or are there any fluctuations in the premenstrual period? Now, a young person, especially if she's talking about irregularities in her periods and mood, fluctuating mood, you want to determine the time period and link to the menstruation. The commonest kind of presentation is more likely to be premenstrual exacerbation of an existing mental health disorder. That is more common, but often they get labeled as PMDD by the patients themselves, and they think they have either premenstrual symptoms or PMDD. So if you look at one of the things you want to do is look at her mental state examination, how she's presenting to you. I mean, of course, you don't have to do a full mental state, but like I mentioned earlier, what you might want to do as you're taking the history, is the time when her mental health symptoms are the most common, but also while she's talking to you, how is she presenting? Is she able to give her history consistently? Is she also very distressed right now? Where is she in her menstrual cycle? And when was the last time, especially the last few days, or when was the last time she remembered feeling distressed by her mood symptoms? Now, this person, it seems like she presented with a fairly well presented mental state. She was able to give her history. She seemed to have had a clear thought process, was able to recognize and respond and appropriately to the queries. So it's possible that during the time that she's come to you, she's not likely to have very active symptoms. So
Okay.
again, linking up with when her menstrual cycle was is very important. Now, apart from the baseline investigations, like we mentioned here, we definitely want to do her full blood count to see if there's any anemia, thyroid function test, any liver function test. So, in her, if I understand correctly, Dr. Rona, the prolactin level was raised, and that
Yes.
can be possibly due to the medication she's on.
Okay.
Dr. Prabha also mentioned that psychotropics, and its impact on physical parameters. And we know that antipsychotics, many of the antipsychotics have a potential to increase the prolactin level, which itself can result in changes to the menstrual cycle. The From what I understand, this patient, the main thing we need to now differentiate is what is the um, what is the difference in her presentation. So I understand, sorry, I think I keep moving forward. So, Dr. Runa, I understand that one of the difficulties she had was in what she presented afterwards, right? So,
Yes. Yeah.
maybe you want to talk about this, and then I can talk about the rest of the
Yeah.
management.
So, because of the GI symptoms, the raised transaminases, I had organized for her to have an ultrasound abdomen, and I said, well, please do consult with a physician in view of her GI symptoms. Because this was kind of pre-COVID, I think we lost her to follow-up, and it was 2 to 3 years later that she actually came back again. And when she had come back, she had gained a significant amount of weight. Her BMI was 40. And she said that her cycles were irregular and she had severe premenstrual symptoms. Now, this time around, even seeing her, she was in a tank top. This is a busy clinic. She's in a tank top at 10 o'clock in the morning. Her hair was dyed, very obvious tattoos all over the body. There was obvious, and because this was a tank top, you could see the entire arm and lot of self-harm marks. But she was very clear in her speech in terms of giving the history, saying, well, she had a lot more diagnosis after. She'd met up with a psychiatrist, and she's very clear in her thought process. She had normal perception, I thought, and was very clear otherwise. And this time around, now obviously 2, 3 years after college, she was living with her partner and was currently unemployed. She said she couldn't hold down a job for too long. That was what she said. So now, how do we assess and manage her mental health?
Yeah. So this is the stage where you might, if she came to you just now, because you have had the past history, you've seen her a little bit before COVID, where the premenstrual symptoms were not very significant, but they were just emerging. And now, afterwards, you're seeing that the premenstrual symptoms have become very severe. And so and there is also a lot of weight gain. So unfortunately, our patients who present to us are not very clear cut, and say this is the set of symptoms. But here you can see that the mood disorder that was getting treated perhaps may or may not have had full resolution, but definitely started having its impact on the on premenstrual mood. Weight gain is a very common risk factor for medication, but weight gain can also have an impact on premenstrual presentation of mood disturbance. So, if we look at trying to distinguish between just having premenstrual symptoms and premenstrual dysphoric disorder, what we know is in premenstrual dysphoric disorder, they need to have at least 5 symptoms. This is according to DSM-5, but the criteria is more that it should be in the week before the periods begin. And actually, when the periods begin, the symptoms start to settle. So sometimes women who may have just a poorly treated depression with little correlation to the menstruation in terms of premenstrual dysphoria, they actually will feel a lot worse when the periods start, because their ability to manage pain and discomfort is worsened, and it worsens their mood. So this thing of premenstrually having a lot of symptoms, especially like affective lability, so they're moving from feeling excited about something and then crashing, feeling suddenly very sad or tearful. They might be very sensitive. If something goes wrong, they're just not able to cope. They might get irritable and angry, especially in the context of relationships, friendships. So their irritability is more directed towards people close to them. Their mood also might suddenly dip. And often, especially, people who are at a high functioning level, they will keep carrying on. They may not express this, they may feel anger and irritability to someone, towards someone, but they may not show it. So what they will actually end up doing is feeling a lot of internal dip. And often they will only come. This person is, of course, giving you a good history of before and after and saying, there is a lot of irritability. But sometimes high functioning women will just say that about a week before periods start, I just feel extremely low. I feel like I don't have any energy left in me to do anything. So this feeling of what is the point of doing all this? Again, next month is going to happen. Again, I'm going to experience this. So, just judging themselves, feeling a very low. Sometimes that's the only thing you might see. And you have to dig a little bit more that, oh, there is a lot more happening around it, that they're just not expressing themselves. And it seems to be especially during the week before periods start. And women who are a lot more organized will be able to tell you this, because they may be tracking their cycle. But what you may need to do to assess and get a confirmation that this is actually exacerbated during dysphoria, during premenstrual period, is to ask them to track their mood, and not just mood, but their behavior related to their mood for at least a few months. And they mark the dates of when the period started, and every day they track their mood and irritability. So what I tend to do is say, notice what you're feeling on the inside, and notice how you're reacting on the outside. So then they just mark those two things: feeling really awful, fighting with everybody; feeling all right, had a good time with friends. So they can, that's easy for them to remember. What are you feeling inside, and how are you reacting to other people outside? And they can definitely see a shift in that week before the periods. And most commonly, like I said, for this patient, she presented with an underlying mood disorder, which was getting worse during the premenstrual period. So there is an exacerbation of maybe sub-treated or poorly managed, in terms of different medications are being tried, it's not helpful. So that is the most common thing you'll see. Now, of course, someone comes without a history like this. Then what you need to know is, how do you differentiate between premenstrual symptoms and PMDD, which I'm sure most of you will be aware of. But just in terms of PMS, is definitely more common compared to PMDD. And premenstrual dysphoric disorder is a lot rarer even now. With the changing lifestyle, there is at least increased awareness, increased presentation of PMDD. But what we know is the debilitating nature of PMDD is a lot more. Women with just premenstrual syndrome, where they might feel a little irritable, they might feel a little uncomfortable, but they're able to function in that premenstrual period as well. So the severity in PMDD is a lot higher, and the changes to their mood is a lot more intense. What they're feeling is a lot more intense compared to premenstrual syndrome. Now, there may be also severe breast pain, severe significant bloating, intense joint and muscle pain. So these things are important to elicit, even if they just come with mood symptoms. And their functioning is affected significantly. And if you remember, when I mentioned this high functioning people, they sometimes, unfortunately, will only come when their functioning gets affected. So they might be suffering in silence, and if you trace their history back, they might say that, yes, I've been having it for a while, but I was just able to carry on, and it's gotten worse. And only because it's affecting my work, I've come to get help. And what you want is, like I said, at least 5 symptoms of a range of, mood symptoms plus physical symptoms, and at least 3 to 4 cycles they need to have tracked to give you a clear idea of, um, in terms of confirming that it is PMDD. So, Dr. Runa, I understand this is what you want to address the slide, and
Yeah,
then I can.
she had been on OCPs before and she felt that it didn't suit her. It actually made her symptoms worse, according to her. So she didn't want anything with estrogen. So then we talked about progesterone. And since she wanted contraception as well, when we discussed progesterone, she was quite happy to have the Mirena. So we fitted the Mirena July 2024, and 6 months after, she was amenorrheic, and the last review was a few months ago. So because she's had amenorrhea, obviously she's not had any bleeding, any spotting. So she then said, well, she had no premenstrual symptoms at all. And at that consult, then she said, well, I'm planning to see the psychologist because she tried to OD a few days prior to the consultation. And yeah, so how would you? I sent her off to the psychologist, and I also said, well, if she's tried to OD, she might benefit from seeing the psychiatrist as well. So,
Yeah.
how would you treat her further?
No, I think what you did was essential and possibly a missing step in her presentation till now. We know that, of course, there is a role for psychiatric medication. And from what it emerges for many of our patients is that even if they've had a good psychiatric assessment, what they end up doing is they either go doctor shopping because they feel like, okay, this medicine I have to take for a few days, then they stop taking the tablets. They don't register that antidepressants need to be taken for a longish period of time, at least for 6 to 12 months for the full effect to kick in. And the kind of combination of medication she was on, sometimes what happens is they take advice from one person, then go to another person, then add those medications, or they don't take it very well, or they haven't followed the rest of the advice, so they keep getting added with new medications. So ideally, the best way to start addressing for someone like her is to narrow down if she doesn't have, uh, you know, um, other things like psychosis or severity of mood symptoms. If you send her to a psychiatrist, the psychiatrist ideally has to streamline the medication. For PMDD, especially if it is just premenstrual dysphoric disorder or premenstrual exacerbation of, say, anxiety or depression, just an SSRI is enough. But what actually has the best evidence is the regularization of her all cyclical systems. So making sure she's eating on time and a healthy diet, um, and a well balanced diet, especially the diet that can address not just weight gain but fluctuations in weight. And often women with PMDD or this sort of premenstrual dysphoria will tell you that their eating patterns are haphazard. They might eat, a heavier meal in the evening and skip their breakfast. So just getting their diet and metabolism to a steady rhythm can be very helpful. The single most evidence, this is probably what you guys know because my obstetric colleagues tell me as well, is that the best evidence is for regular exercise. The biggest problem I have with young women who I see is they want to go for something very intense. They go for HIIT and running, and they want to run 5 kilometers and 10 kilometers. But the consistency and maintenance of that kind of exercise is always fluctuating. So either they're going all out and doing some high level exercise, or they're not doing anything. So what is actually useful is not necessarily how intense or how heavy they're lifting their weights or whatever, but it's how regular and moderately they're doing, because maintaining the rhythm and regularity is more beneficial, especially for regularizing the menstrual symptoms and premenstrual mood symptoms. So diet and exercise, those are the two most important things, of course, but just in terms of how they address. And women with depression and anxiety are the ones who are more likely to, chop and change, to drop it when they're not feeling up to it. So the way we ideally would like to address from a psychiatric point of view is this way. But again, like you say, like you see in this case, collaboration between the two teams is very important. So, what you did there, referring to a psychologist, is actually a crucial part, because sometimes just the medication and is not enough. Even helping her to make changes to her lifestyle, psychological treatment can be very helpful. So referral to a psychologist is actually the main part of the treatment, and the other things are there to make sure that she can keep her regular cycle. We did have another case, but I think in interest of time, we won't go into it. Dr. Rona, did you have anything else to add before we stop?
I was just looking at some of the questions. One is what is the role of family in such a scenario? Now, for a bit of background, the mother, I mean, she comes from a single parent family. The mother was the primary carer, and the mother herself actually had, I think, a mood disorder that she was being treated for. And again, so that was a bit unstable in terms of her mother going for treatment, and then she lost her grandfather after. And with all the trouble at college, I don't think she actually had good references in terms of a job. So yes, I think family will be important, but it's not. It doesn't happen in a lot of cases.
I completely agree. I think the role of family is actually to educate and not stigmatize the patient. I think often the patients feel a lot of stigma from the family. So if the family is involved and if there is some kind of distress coming from the family, then educating them is what might be helpful.
Yeah.
I haven't followed all the questions.
One question was family that I looked up. Any questionnaire for PMS? I suppose we can use the criteria and see whether their symptoms fall into that category. Yeah.
So I'll request you two to kindly answer the queries in chat box if possible, ma'am. Thank you. We'll go on to the next discussion, ma'am. The next discussion is going to be done by Dr. Prabha Chandra once again with Dr. Shamima Anwar Sarda. And sorry for the pronunciation, ma'am. Hope I have pronounced you correctly. The chairperson again is Vishali ma'am. Vishali ma'am, would you like to add something to previous discussion, or we
Yes.
can move on to the
Yes. Thank you, Dr. Ashlesha and Dr. Runa. It was a very practical case-based discussion. And thank you for sharing the knowledge, which is very important practically. And we see these patients and we really feel helpless, but you guided us with very crisp messages. Thank you so much.
So Dr. Shashi has joined. I welcome Dr. Shashilata Kabra to join Vishali ma'am as chairperson for the next session. The next session is, as it's visible on the screen, Dreams, Desire and Distress, the emotional journey through fertility treatments. So the discussion, I invite Dr. Prabha Chandra and Dr. Shamima ma'am. Over to you, Dr. Shamima. Prabha Chandra ma'am has already been introduced. It will be a pleasure if we get the CV slide of Shamima ma'am, or Shamima ma'am, you can introduce yourself.
Good evening, everyone. It's a great honor to be here, especially talking with Dr. Prabha. And I am Dr. Shamima Anwar Sadat. I'm a senior consultant in Aster Medicity, Kochi. I'm also part of IRC and South Zone, and has been running this perinatal mental health course from since the time we started in 2021. So very honored to be here, and we are here to talk on mental health in infertility and ART. A lot of dreams, desire, and distress, and it's an emotional journey. It's a emotional journey of the fertility treatment. So, excuse me, I'm not able to. Yeah. So infertility is like quite common, affects 10 to 15% couples globally. It's a high stress life event, as we know, causing significant psychological burden, and mental health problems are reported in about 25 to 60% individuals, and the different way it presents as anxiety, depression, loss of self-esteem. And many studies find that the level of anxiety and depression is more among women, even if The male factor infertility is being treated. Women are getting more psychological symptoms. So it presents as anxiety, depression, stress, etc. So, Prabha madam, what are the factors that lead to stress in infertility treatment? What are the different ways it presents?
I think one of the first ones, as you know, is the social pressure to have a baby. I mean, I think there's pressure from outside and there's pressure from inside. For a lot of couples, it's like an automatic thing. You get married and you have to have a baby. And when it doesn't happen, it's like your life plans have suddenly, changed or halted. So I think that's one thing. But there's also a lot of stigma around it. Many people actually don't even share with other people that they're going in for fertility treatment. So there's secrecy. Um, you may have, all the gynecologists know that, there's a lot of blame put on the woman. It's like, it's because of you that my son is not having a baby, and there's, that you are working too hard, and that is the reason why you're not having a baby. Stop your career, or stop your studies, or you got married too late, and that is why it's happening. So I think the kind of pressure that they put, it's almost like you are to blame in some way that you're not having a baby. So I think that is another big pressure. And I think this whole concept of what is called cyclical grief, that we say that with every period there is grief, and every time there is a failure of either the IVF or the ET or whichever it is, again there is a sense of grief. So it's almost like you're grieving something that you never had. It's like an invisible grief that you're facing, unacknowledged grief. Nobody from outside will realize what the problem is. So then, of course, is the financial strain, without any guarantee that it'll be successful. So I think that's the other problem, and the kind of time that you have to invest. Many women actually hold everything. They don't do their MDs, they don't do their PhDs, they don't go back to work, only because they have to spend so much time in relation. So I think all of these together are a very, very stressful. It's a recipe for severe stress, actually.
So that shows that psychosocial support is as important as how we medically help them. So there is a guideline by ASHRAE on routine psychosocial care in infertility and medical assisted reproduction, and it has about 120 clinical recommendations, and it says that psychosocial care is a routine care. It is not optional. Not you don't have to refer. It should be integrated to the daily workflow and should be delivered by all fertility staff. It is not only for the psychologists, and it should be continuous across all stages of treatment. So we know that there is a pre-treatment phase, during treatment phase, sometimes the treatment will fail, and that time also we need support. So Prabha madam, how will you go through the each phase? What all things we have to address in each phase?
I think, like you rightly said, and rightly so, that the fertility specialists are very keen on basically getting a good outcome, getting the woman pregnant. But I think somewhere along the way, the mental health is not addressed adequately. So just trying to understand the woman's life situation when you see her the first time, the kind of stress that she's facing, any other pressure she's facing, I think is important. Also, not setting, depending on the cause, the realistic hope is very important. And I think sometimes they don't get the realistic hope. It's more like, oh, we've had such great success rates in this IVF clinic, without recognizing that women need to be told what are the chances of, couples need to be told of a little more realistically. And especially during waiting periods. I think it's the 2-week period wait after the ET is really very traumatic, after the embryo transfer. And before that, once the egg retrieval is done and you're trying to get an embryo, that is also a very, very scary time, where they're very worried that the embryos won't be there. And if you're doing PGTA, then aneuploidy. So I think every of those stage, you can imagine what the woman is going through, and trying to see how you can support. And when it all doesn't work out after the cycle, then also I think just being present. Sometimes there is no right thing that you can say. What can you say? You can't say I'm sorry, because you didn't do anything wrong as a fertility specialist. So I think the important thing is to say, I can understand how distressed you must be. I can see that this has been a huge disappointment. But you know what? You tried, we tried. Let's see what are the next possibilities. So I think helping them and also helping decision making about continuing or stopping treatment. That's again important. At some level, at some point, we need to kind of say, okay, let's take stock of what we've done till now. Let's have a discussion about where we'll go from after this. I think that's important. And some women who you find are crying a lot, who are telling you they can't sleep, I think they will need specialist counseling or psychotherapy.
Okay, madam. So most of the time we'll be counseling them after every scan or something, but we will be focusing on the number of follicles, the hormone levels, and so this part has to be addressed by everyone. That is most. So then how can we do a psychological assessment or when they come first time or to undergo a fertility treatment? Is there any, we have to use a screening tool, or how it has to be done, a psychological assessment?
Thanks, Shamima. That's a great question. I think, like Ashlesha said, sometimes, screening tools kind of restrict you a little. So just checking, have you had any treatment, any counseling, any therapy in the past, which will give you an idea that this person may be a bit vulnerable. Asking about the relationship. I think in fertility treatment, the husband-wife relationship is very, very important. Asking about any other pressure that she's having on her related to this. So some of those issues will tell us, is this woman more vulnerable to problems? Is this couple more vulnerable to problems? Because some couples have great difficulty and have lots of issues with each other, and fertility treatment just explodes that whole thing. So I think just asking very gentle questions that, anybody who comes for fertility treatment, I usually ask them these questions. These are routine questions. I just want to know, in the past, when you've had major stressors or problems, how have you been able to deal with this? Because fertility treatment is a stressful journey. Second, have you ever had counseling or therapy in the past? How did it help? What did you have it for? What's the stage? What kind of a relationship do you have with your partner? How understanding is he? Is there any other pressure from outside family members about this? Like how much? What does this mean to you? So I think that is a very good tool. And like we said, there's a very good method. So just a chatting, a conversation is much better than putting any questionnaire. But there's a questionnaire called Ferticall, which actually a lot of people use, and you can use it at every time that the woman comes to you. So it doesn't have to be only the first time. It can be done every time the woman comes to you for any kind of procedure. You can, because things can change. Initially, high level of motivation, but every time there's a failure, there's a sense of disappointment. So the relationship, how is it? How are you feeling? I think that's something that and this Ferticall, people can just, this is a QR code, and it's there in many languages. It's there in Malayalam, it's there in Hindi, it's there in Kannada. Many languages Ferticall is available. So people can actually use it as a tool. It's not anxiety, depression. It gives you a good quality of life kind of a questionnaire, which is equally important, I think, because it looks at emotional, it looks at mind-body relationship, it looks at relational and social. So I think it's a very, very useful thing to do.
So it is like, it is not static, it can change over the treatment, right? So and when do you think, madam, usually this is to be done by the fertility team only, but when do you think directly referring to psychologists, like what are the red flags which we think that like directly they have to be sent to a psychologist or a psychiatrist?
Yeah, so I think ideally, and we know that now the government has said all fertility centers should have a counselor, right? So,
yes,
but the counselor there more focuses on treatment. This will be your
exactly.
treatment. So it's not really counseling. It is just educating about the procedure.
Yes,
I think one should have like a proper counselor, like who's trained in mental health within the system. I think unless the woman is showing signs of depression or is very, very anxious or has had repeated failure, then you might want to refer them to or ask them, sometimes it is very, traumatic, all of this. Would you like it if you can see a therapist? I know a therapist who specializes in fertility situations. So women also like to go to therapists who know about fertility treatments and infertility. because not every therapist is actually aware of many of the things. I mean, one assumes that all mental health professionals will know everything. They don't know. So I think identifying those people who know, but also trying to have some sort of a counseling facility within your system. I know that there is yoga, there is acupuncture, but that's again to improve equality. That's not so much actually for the woman's relaxation. Groups help a lot. So actually having a therapist who's facilitating a group of couples or women who are going through fertility treatments where they can share their stories. I mean, Shamima, that the maximum information that women get and support that women get are from Reddit groups. They go on these, and there are many fertility Reddit groups. They go on these groups, and that's where they're getting support. That is because they're not getting support from our system. So I think developing some of these methods is very important.
Yes. So the counseling register which we keep in according to the National ART Act it's not sufficient. We have to go beyond that and assess the mental health symptoms and clear referral if needed. Yeah. So these are the key practice recommendation. Routine psychosocial screening, staff training in communication and emotional support, early identification of patients who need help, and clear referral pathways should be there. And patients should be given opportunity to discuss their emotional impact, not just their medical issues. So these are the.
I mean, I also find that like you said, staff training. No, see, when you're waiting for the doctor, the receptionist is there. There's a nurse. There's a person who tells you about procedures. They are very sharp many times. They will see the interaction happening. They will see the woman looking very distressed. You may have just 15 minutes with the patient, but they will be seeing all this. So I think it's important for them to also alert you. That, ma'am, I think this woman's going through some problems. So it's good to do that staff training also.
Yes, good. So we will come to a case. This is Mrs. Swati, 32 years, and Vivek, 35 years. They are married for 3 years. She has delayed cycles and has some diagnosed of PCOS. Semen analysis has been normal, and they want to have a child, and they had undergone ovulation induction, but they never underwent an ultrasound monitoring or anything. The problem for them is they cannot have intercourse. That is, like, whenever they are asked to do the intercourse, they are not able to perform. I mean, they are not able to do so because of the pain. And she has tried some self-insemination also. So finally, they have come here. They have come here asking for IUI. She has severe dyspareunia, vulval hypersensitivity. She was ready mentally for a scan, but it was highly painful and difficult. Organic causes were ruled out, and now we have to refer her to we referred her to our psychologist. So how this problem has to be approached? This is very quite common these days, the vaginismus. So how will you approach this case, madam?
Thank you, Shamima. I think vaginismus is a common, like you said, not an uncommon problem, particularly in those with fertility issues. And that
is very common. Today itself, I saw 3 cases, madam. So
I think it's probably because they come to you for fertility issues, right?
Yes.
And I think that is where a fertility specialist should first start with, are you having regular sexual intercourse? Because many couples just come, we've not conceived, but actual problem is because the sexual intercourse is not happening. We now call it fertility genital penetration disorder. So the terminology has changed a little bit. Genital pain and penetration disorder is what the condition is called in DSM. And like you can see that's because of the fear of pain. So it just spasm happens. So very often it might be related to anxiety, lack of knowledge, about sexual intercourse, the stages of sexual intercourse in both parties. No lubrication and trying to penetrate can often make the woman really fear pain, and then she just goes into a spasm. It's a learned reaction. Pain, as you know, is a very, very important learned response of the body. When you feel fear of pain, there will be a pain response. So I think important to check what this is related to, how did it start, and there are ways of managing it. Psychological treatment is very important in vaginismus because there is a learned behavior about pain and the response of pain and fear, and that should go alongside. We give pelvic exercises, relaxation exercises, dilation, vaginal dilators, which are done very gently. You can't start with vaginal dilatation. Sometimes you feel that will work. Then there are other sex therapy like sensate focus. So basically, don't focus on penetration. Be intimate in other ways so that adequate lubrication happens. So a lot of partner education is also needed. So if there is vaginismus, I would suggest the first thing you should do is to refer to a psychologist, because they will be able to manage it. Medications have very less role because it is all very local. So if the vaginismus is a problem, refer to a psychologist for all this treatment that we have discussed.
Okay. So this Swati, she underwent CBT. She tried 3 IUI cycles with us with lot of psychological support from the team, and then but unfortunately it failed, and she decided to go for IVF FOGSI. So then she, like, when we started stimulation, we were like worried. I mean, more than us, she was worried about the OHSs during stimulation, because she was googling and finding out what these stimulation can, how it can be harmful to her. She was focused on that, and she was even admitted with bloating sensation after OCR, even though there were no features of OHSs. And when she underwent ET also, she was more worried about whether she will get multiple pregnancy rather than she will get pregnant at all. That was our worry. But then her worry was she insisted on single embryo transfer. So fortunately, she's pregnant now, 12 weeks, but still doubtful whether she will have miscarriage, or am I really doing well, and whether something can happen. This is her. So there is a what do you think, madam? There is a baseline anxiety for her,
I
right?
think so. Yeah, I think Shamima, here it looks like she is an anxious person, and she probably has a generalized anxiety disorder. She approaches everything with anxiety,
Yeah.
at every stage. And like you said, OHSS is a problem, but the percentage is so low. She knows that. And excessive Googling is another thing which a lot of women going through fertility treatments do. They know sometimes more than what we do. We know about newer treatments, immune treatments, all kinds of things they are aware of. They'll question the fertility specialist. But here it looks more about anxiety.
Yeah, such subtle things point to the anxiety in her, because she looks generally cheerful, and they are a very nice couple. They, I mean, support each other. But these acts, remind us that.
Yeah, because anxiety is something which they will not be depressed or sad or anything like that. But there's a lot of rumination going on in the mind. The same thought going like a loop, I'll get this, I'll get this, what will happen, things may go wrong. So that is a ruminative thinking, which is part of anxiety and a little bit obsessive in nature. So definitely CBT will help. I don't think at this stage you may need to go for medication, because already precious pregnancy, you don't want to add a complexity. However, if it becomes too much and you think that with CBT also it's not working, then a low dose of SSRI is all right, especially after 12 weeks.
Okay. And we have to be very careful about our postpartum and period also, right, ma'am?
Yes. In fact, I've had women who are so stressed that they don't bond with their baby after so much difficulty, they get the baby. And they're like, no, I'm so exhausted with this whole thing. Now take this baby, you manage. And, I don't feel bonding towards baby. So I think very important to handle some of these issues.
So we'll go to the next case, madam. That is, we had Tina, 28 years, and Miss Sam, 32 years. They're a doctor couple with 3 years of unexplained infertility, 4 failed IUIs. And then she came to us for, actually, her mind was prepared for IVF, but she was asking, why is this happening to me? So this is the question most of them ask. Like, they are quite healthy, and their family, there is no history of any such problems. So she's asking, why is this happening to me? So how can we answer this question, madam, actually?
Yeah, I mean, even when women have low ovarian reserve, or they have endometriosis, or they have any other problem, even then the why me question comes, all my friends are having babies. Everywhere I look around, people are having babies. Why me? So I think when they're asking you that question, they're not expecting a concrete answer there. I think they want to talk about how they're feeling. you know.
Okay.
So you can say to them that, you know, I completely understand how you feel, that, you know, everybody's having babies. Why is this happening to me? Sometimes nothing is wrong with me, then why is it happening to me? You know, and I think one is to give a scientific explanation about what is happening, but even more than that, to acknowledging the helplessness that they're feeling, you know. And you can also say sometimes we may not have all the answers, you know, but I understand that it's not so much that you want the answer, but you're really very distressed by the fact that you're in this state. So I think they want to talk about their emotions. A why me question is always about emotions, you know. It's not about knowledge so much.
Okay. So, madam, then they came for IVF. They were very hopeful, and we were also hopeful because young, good ovarian reserve, chances are good, we told them. And as expected, we had good number of good quality embryos, and she had a perfect day 5 embryo transfer, but the beta HCG came to be negative. Then she asked why everything was fine, and then why this happened. So this time, how can we answer what went wrong? That is what she's asking. So medically everything was all right, but still we can say that some embryos will not implant, and sometimes this happens. Not all, it is not always 100%. But like, we tried to tell her that we still had embryos, so we will try again. Is this the right way to tell, or we have to tackle? Sometimes they will be like, they will lose hope and discontinue the
I mean,
thing only.
I think being realistic, you know, if in this situation, I would say that everything is fine, right? Is good ovarian reserve, embryos are good, she's young, no comorbidities. I think it's only right for you to say that sometimes this happens. You know, implantation failure rates are quite high, even if there is no cause. You know, you have more embryos, let's try again. So not being super hopeful, but at the same time, not being defensive, but kind of saying that, you know, it happens. Even in nature, it happens that implantation doesn't happen. So I think giving that very realistic response at this stage.
So even though we never suspected anything before previous history of polyp and all, we did hysteroscopy, but then she thought that there will be a polyp, it can be removed, but it was normal. And then we changed the protocols, we did a lot of investigations, and she had further transfers, and she had another egg collection, and she had fresh transfer, but all came to be negative. We didn't have any answer. And she was thinking like, at least if something I find wrong, I can accept. She asked for endometrial, ERA, endometrial receptivity assay, which we routinely don't do now, but we did everything, but then everything was perfect. So then each cycle she became less and less hopeful. Like, she was like mechanically coming and doing like that. So she had some 4 cycles. Even she had outbursts with the staff when some result was not communicated to her or something. She had some outbursts. So at this point, I thought like she needs really a cycle. But being a doctor and a specialty, she's in a super specialty. So I couldn't force her to go to the psychologist. She told she can handle herself. But what do you think at this point, when the failed cycle, they need a
I
psychological
think,
support?
like I said, no, it's like a grief reaction that, you know, and as you rightly said, with each cycle, hope goes off. And that's very traumatic, you know. And clearly she was getting angry because I think the anger was not at you, but the staff, but the anger is at the situation. And the fact that she's losing temper so much indicates that she is probably going through a mild mood disorder, like a depressive problem. And she may not agree to go to a psychiatrist, but you can say that, look, you're going through a lot. Every cycle when you don't get pregnant, it's like a grief, you know. Sometimes you need to take some support from somebody. Would you consider seeing a therapist? Because it may help you to manage your emotions better. I think so. Putting it in that sense, not labeling her that you're depressed, you're this thing, but saying you'll be able to manage your emotions better. If she says, no, I can do it, then it's different. But, you know, that's something that you could try. But I also feel that you are, as a doctor, as a fertility specialist, I think you are the one who's going through even more equally, if not equally,
Yes.
as much stress. Yeah.
Yeah. So she used to read everything regarding IVF. I used to tell her that I can give you a fellowship on IVF. So husband is supportive, but he was not, carrying the same weight of failure. So as a fertility specialist, I was also very depressed to see her only, and I searched with so many people. Everybody told like we have to go on transferring, as she has a lot of embryos. We'll go on transferring. At one point, you will get the positive. And before the last transfer, she happened to meet her friend who had multiple failed IVF cycles, and she succeeded after multiple cycles, maybe 7 or 8 cycles. She went for some party for the baby, and then after talking to her, actually her hopes, she came and told me that, madam, I am not going to stop, I'm going to go on, I'm not going to stop, I will continue till it becomes positive. So that change was there in her. And the final transfer, we did some protocol changes and all, but I don't know what worked. She was positive, and once she was positive, we were worried whether she will have some miscarriage or something, but she continued to be very positive throughout the pregnancy and delivered a healthy baby boy. That is what happened.
Yeah,
So
it's a good ending to the story, but it could go either ways, I think.
Yeah.
And I think, like you rightly said, your own mental health as a fertility specialist, I think, is also equally important. Sometimes when people have repeated failure, you don't feel like meeting the patient. You're like, oh my God, she's come again. What am I going to say? How am I going to face her? But I think you're the only one who will understand. So they need you. Regardless of whatever, you should feel that I've followed evidence, I have been honest and ethical. These are two things you can do. More than this, you cannot do, right? So you should not feel the sense of failure. So the fertility specialist should not feel a sense of failure. They should feel, have I done everything ethically? Have I followed evidence? And that is all you can do. So I think focusing on that rather than taking the failed cycle as your failure is very important. Creating that distance.
So usually the pregnancy after ART, like a precious pregnancy, it's called, and usually it is associated with high anxiety levels, right, madam? So in early pregnancy, especially.
Particularly early pregnancy, I've seen after the second trimester sets in, they're usually settled. But especially because if they've had previous miscarriages after ART, then it happens, more anxiety.
So do you think like we are always focusing on the female because they are the ones who are constantly coming to you for the monitoring and everything? Does male partner also need support?
I think they do. But the rates of depression and anxiety are much higher in females, even if it's a male factor infertility, because it's the woman who's going through everything, no? Every time. The men are not going through so many procedures or anything like that. So I think that may be the reason why men also struggle, because at home they have to handle all the repercussions of it,
So as you told, they need, and also the impact on fertility specialist. How as you told, madam, fertility specialists, if they have done everything in an evidence-based way and whatever possible is done, then they should not be blaming themselves.
And I think actually having conversations with a woman also help. If you avoid her, you'll feel more stressed out. I think the important thing is to you should not tell your junior to see her after 4 cycles. You should be the person who's sitting with her, because the woman is already distressed. She may think, I have annoyed my doctor. Because I'm so fussy and I'm demanding, she's upset with me. Those are the kind of thoughts that go on. And I think you have to be present. You have to show up. I think that is very important.
And do you think, madam, all the hormonal medications which we are using for the treatment is also causing some mood changes rather than the situation itself?
Absolutely. I think, drugs like Lupron, progesterone, all of them have mood effects. And I think it's very important. So this is a full table of all the hormonal medications, how they impact mood and how the drug interactions happen. So because there's so much literature on this, I made it into like a QR code so people will have all the information with them.
So, and the commonest drug which we are using in SSR, the SSRI, which is very safe in pregnancy, is found to be the they are the first line agents, and they have not found to increase the embryo aneuploidy or reduction in implantation or liver. So they are safe
this
to
is
use.
a hopeful message for even women who are very anxious or have depression. They can be on SSRIs and it doesn't,
affect the outcome.
I think some people want the QR code, so maybe you can put it on chat or circulate it later, I think, yeah.
Madam, you want to comment on this, like a summary?
Yeah, so I would say that, one, women with fertility treatments need support. The fertility specialist also needs support. So you should have some methods of debriefing, or, having a group of people who can talk, or fertility specialist getting together and talking to a psychologist or a psychiatrist as a group, trying to understand what is the process that you are also going through grief at that point. So, but there are many other, advanced therapies also available. So if you think that the person is not dealing properly, for them it's very traumatic, I think they need more advanced therapy, and particularly women with pre-existing mental health problems will need a referral to a mental health professional.
So the key take-home messages, madam, can you tell, or
you can go ahead.
IVF is not just a medical treatment; it's an emotional journey, and the infertility care. I mean, the persons in infertility care requires a lot of knowledge about the psycho-neuro-endocrine system, and the different stages may require different types of interventions. And so the mental health is as important as every injection, appointment, and lab result along the way. So with that, I think thank you so much. Madam,
Thank you, Dr.
so much.
Shamima. Thank you. Wonderful discussion, Prabha ma'am and Dr. Shamina. I know it's a great discussion we have had with all these, sessions. Shamima, I know it's very exciting, and sometimes the IVF expert herself may feel depressed because of negative results of pregnancy. Being a mother of a IVF expert, means how excited the doctor becomes whenever a UPT is positive in a patient on which you have done IVF. So I'm really thankful that you touched the mental health of attending doctors also. That was a very, very good key message, that doctors also should not lose hope, and you have to continuously morally support your clients, both male and female partner. Thank you, Prabha ma'am, for those clear messages. Over to our chairpersons for their comments. Dr. Corday ma'am, you want to say something, or Dr. Shashi, you'd like to add something? You have to unmute, Shashi. Please unmute Dr. Shashi Kabra Maheshwari.
Yeah, hello. Thank you, Dr. Anita. It was a great session. And both of them have discussed many points regarding that hormonal treatment. And it was a very important point to discuss about doctors' mental health also and hormonal effects. And this discussion was something new for me also, and great discussion. And the reference of RCOG guidelines was excellent.
Prabha man, thank you for those QR codes and very nice, some screenshots I have taken. I'll share in the group so that others can also use it. Thank you so much. So we can go on to the next session. I hand over the session to Professor Meeta Gupta, who is my coordinator for this she's coordinator for today's program. She will be coordinating the panel discussion, which is going to be done by respected Dr. Uma Ram ma'am, who is the main chief convener of this program. And we have very learned panelists like Dr. Hope all the panelists are there. So over to you.
Take it. Yes, thank you so much, ma'am.
Shamila, welcome. Hope everyone. Dr. Bhatti is there. Dr. Ma'am, Meeta Gupta ma'am, you can introduce the panelists.
Thank you so much. Thank you, ma'am. And with this, we come to the final session, which is more interactive after two such brilliant speakers, after initial two sessions where we had such brilliant speakers. So coming to the last and more interactive and more discussion from all the obstetricians, it is my honor to invite the moderators for this session. Yes, Uma ma'am, who is also the convener of today's session. Ma'am is the director and consultant Obs-Gynae, Sithapatti Clinic and Hospital, Chennai. With ma'am is Dr. Prabha Chandran ma'am. Yes, and I heard that she is a very renowned obstetrician of of Bangalore.
I'm a psychiatrist, not an
psychiatrist. Sorry, ma'am, from Bangalore. And the panelists for today's session are Charmila ma'am, Dr. Charmila. Yes, ma'am. Ma'am is the Vice President FOGSI 2024, also the Vice President Trichy Obs-Gynae Society, Secretary Gestosis India Association, the Managing Council member for PCOS Society, ICOG Council member for last 5 years from 21 to 26. The second chairperson for the session is Dr. Shweta Singh. Yes, the third, Dr. Shweta Singh. I'll request Dr. Shweta.
Yeah. She will introduce herself when she joins.
I'm so sorry, Dr. Shweta. You will have to please let us know.
Next, please. Next.
The third chairperson and the third panelist is Dr. Aruna Muralidharan, and she is a consultant, Cloud9 Hospital, Jayanagar Shri Clinic, Jayanagar, and she's an author of book 9 Months, A Journey of a Lifetime. She's a Karnataka Women Achievers Award in Medical Excellence 2023. She's an we'll ask the Poonam, can you please unmute Dr. Shweta Singh? The next chairperson is Kavita Bhatti ma'am, a very close friend of mine. She has done her advanced course in medical education. She is CIMP qualified. She is professor and head of Obs-Gynae CMC Ludhiana. Ma'am presently is the secretary Ludhiana Obs-Gynae Society, president Ludhiana Menopause Society, president Society of Vaginal Surgeons of India, Punjab chapter. And
thank you, Dr. Meeta. I think it's more than enough. Thank you.
Dr. Shweta, could you unmute yourself?
Yeah, I could unmute myself. Good evening, everyone. I'm Dr. Shweta Singh, professor and unit head at AIIMS Bhubaneswar. I've written a chapter on interfaces of psychiatry with my psychiatry colleagues and the Indian Psychiatry Association 2 years back.
Thank you.
Welcome all the moderators and panelists. So over to Umaram ma'am for the panel discussion.
Thank you very much. I think we've had a really, excellent learning in the session so far. So in this panel, we are going to try and basically just consolidate some of the messages that we have heard over the course of these last 2.5 hours. And let me just share my screen. Just a minute. Okay. So we'll begin with what is a very common scenario that we see in our day-to-day practice. So this is a 49-year-old with irregular periods for the last 1 year. And now she presents with 4 months of amenorrhea. And she says she's worried because she has irregular periods. She feels that she's having palpitations and she's not sleeping very well. The husband says that she has significant mood swings and wants that addressed also. So let me start with asking my panelists as to how they would, initially address this situation and what would be your initial responses. So Charmila, can I start with you, please?
Thank you, Uma. When you have such a patient, you would start with the history. Talk with her very clearly about how her cycles were and how it is worrying her. And then the palpitations, or whether they are episodic or they are always happening. Does it happen with stress, or it's a particular time of the day that she starts having those palpitations? We have to take a proper history for that. And then each complaint, you have to actually elicit the history. And regarding the sleep disturbances also, you have to ask her like how, when she goes to sleep, what is the sleep hygiene, what is the patterns which she follows, and how long she's having these problems, and does she have a problem in the daytime also because of those sleep disturbances. All that has to be assessed. And the husband's complaint also should be actually taken into consideration, because that she may not be saying, but that also you will take into consideration. So history taking is very important, I would say. And then the examination of the patient, the clinical examination of the patient. Vitals should be examined, pulse or blood pressure, because of those history of palpitations. Put a steth on her chest and just check her heart sounds also. You can pick up something. Cardiovascular system examination, and general examination for anemia, because many women in this age group are also having anemia, so that can also be a contributory factor to her palpitations. So her vitals, her clinical examination, and then her general examination, and then after the evaluation, then you will start about the investigations, whichever is needed. Shall I go into it, or?
No, we will
Yeah.
take it. Yeah, we'll take it one step at a time. So before we get on to the evaluation, Dr. Shweta, I mean, very often women just assume that all of this is menopause related, you know. So how would you make a so in terms of trying to determine if this woman comes to you, as Charmila says, you've taken a history, you've probed a little bit into each of her symptoms. So how do you make that distinction? And is there anything specific in evaluation that you think you would like to do? Or is this all just menopause moods because of
No,
the
we
stage?
need to rule out the organic disorders also. So she's 49. And regarding her palpitations, Madam has told, Sharmila Madam has told very nicely. But couple of things I would like to add is, when does these palpitations happen? Is there any organic disease, heart disease? Is there any arrhythmia which is happening? So an ECG we will get done, and maybe an echo, see her blood pressures correlate with that. Organic diseases we need to rule out before we say that it is because of her perimenopausal transition or being in the perimenopausal phase. And how good is her support system? Like husband says, so okay, I will also discuss it without her husband, how good she is, how supportive he is, how valued she feels, whether there is any emptiness syndrome. So what times does she get these palpitations? Is it in meetings? Is she working, not working? All those things. And then many times we will get, okay, nothing else, maybe these are the only things. And yeah, then the routine tests, that in investigations, the routine tests for her perimenopausal age group and
That's fine.
LBC. Yeah, all those things we will do. But basically this, then we do because amenorrhea is 4 months now. So then we go to the
Fair enough.
FSH levels and come to the other things.
Okay. So I think for the purpose of this discussion, we'll keep it around, not getting into the cycle per se at the moment. But Dr. Prabha, do you want to come in here and say anything about how do we, because this is extremely common scenario, where women and actually the husbands often more than the woman assume that a certain amount of mood change is common in menopause.
Yeah.
And how do we then distinguish this is
So, sometimes it can be a combination of everything. You can't say that just because, let's say you find that there is some TSH increase, okay, or you find that there is mild anemia. That may not entirely explain everything, but it may have contributed to it, because this is also a time when a woman is both physically and psychologically vulnerable. So, keeping in mind that it's not like you find something that it can rule out anything else, but also asking a little bit more about the mood swings. Like what do you, people use mood swings very casually sometimes. So kind of saying what really happens, does she start crying profusely and then finds it very hard to stop? Or does she get angry a lot? Does it happen like daily, every day for a long period, or it's once in a way? I think getting a little bit of a better idea about the mood symptoms, does she sometimes feel so angry that, or so upset that she feels suicidal? Sometimes these things are important to check, because only then you know the severity. So also, like some people said, now the sleep problem may be also related to the anxiety. So we know that when we don't sleep properly, when there's a lot of sleep deprivation, you get up in the morning and there is a lot of anxiety. palpitations can happen because you're so exhausted. So I think trying to understand the mood symptoms in the context of number one, is there any physical reason why you can get it? Is it out of proportion to that? Because mood swings you may not get with anemia. Palpitations you may get, but not mood swings. Mood swings you'll get with maybe thyroid problems. But how severe is it? So I think trying to understand that and how much impairment is it causing? Is it just that it happens once in a way? Or is it causing so much that, the husband is finding it very hard, maids are leaving work and going off, the colleagues are saying like, what's wrong with you? So your juniors are like completely frustrated with you. So I think the severity is also important for you to decide, should I treat, should I not treat?
Okay, fine. So thank you, Prabha. So Dr. Kavita, so if you have done the evaluation and then basically she's not particularly anemic, TSH is okay, the cardiac evaluation is normal. So what would be your advice besides cycle regulation? What would be your advice to this woman, and how if she was sitting in front of you, how would you counsel her?
So basically, once you have ruled out all the organic causes, as you said, anemia, thyroid, and the cardiac evaluation has been normal, I think she fits into that perimenopausal phase of life, and therefore she's having all these symptoms. So check on the FSH, LH, and you can determine whether she really falls into that menopausal phase of life. And then you have to address other issues. Maybe you can even ask her any other histories which may be relevant, like hot flashes, which will again direct you towards the diagnosis of menopause and what is troubling her most. So then you can tailor your treatment according to the most problematic problem that she's having or symptom that she's having. And like mentioned earlier, any triggering factors which may be present, like a emptiness syndrome or relationship problems, and that also needs to be addressed. Look at her BMI, and lifestyle modifications may be advised. And the basic treatment for perimenopausal age group that we give antioxidants and vitamins, then calcium, vitamin D, that also should be I think, given to her before we go on to the next step of treatment.
Okay. So thank you, Dr. Kavita. So Dr. Aruna, so let's say, we have evaluated her and you are able to sort out that a lot of this is, probably perimenopausal symptoms. At the same time, when you explore a little bit more, you find that she's actually quite teary. She says that she's not able to cope. So in what would be a referral pathway in practice? Is there because one of the challenges we have is we realize that there is a mental health component to menopausal, care of women. So in your practice, is it easy to refer? What is the referral pathway? What is the acceptance? And because each one is from a slightly different practice setting, we'll get the public health opinion also, public sector opinion also.
Yeah, absolutely. Am I audible?
Yes, Aruna.
Yeah. Hi. Thank you. Thank you for that question, and thanks for involving me. Lovely discussions. But in this particular case, I think it's important to understand whether this is a constant feeling that she has, or is it more of a waxing and waning sort of situation? Because we all know that menopause is not just, estrogen deficiency, it's more of a fluctuation of estrogen. So very many times they have waxing and waning, and they're completely normal and happy, and absolutely careless, but sometimes they really feel awful. So I think that cyclicity or continuity has to be established. And I think in my practice, I would like to delve more into the actual symptom and the quality of life portion, just like Dr. Prabha said, and try to determine whether it is a severe variety of, let's say, depression or anxiety. So I think it's important to understand the effect on her quality of life and the number of weeks that she's feeling that at, how many days a week she's feeling like that, and how much is sort of disturbing her relationships and work. Also, the sleep disturbances can contribute a huge deal to how she's
Sure.
feeling. So many a times it's a gateway towards mood. If the sleep gets better, the mood gets better automatically. Because we all know that serotonin and GABA and all that is playing a big role here. So I think first thing is, if I would see that there is something more than the usual perimenopausal, it's more than what seems to be normal for a perimenopausal woman, then I certainly would like to get a psychologist initially for counseling, and probably even eventually, if there's some sign of severe depression, anxiety, to refer them to a psychiatrist as well. Also, if I'm a little uncertain about about how she feels, and she's also unable to sort of, let's say, explain how she feels, and the husband is definitely saying that a lot of fluctuations happening, I probably would like to refer her to a psychiatrist. But as my other co-panelists have said, we start with lifestyle, we start with sleep hygiene, we start with all sorts of other things like exercise and yoga and pranayam and all that. And if there is no benefit with all that, I think we will then have to think about some sort of integrative approach. It should be definitely, this is the point where I would think about integrative approach, probably HRT, probably CBT, probably antidepressants, but also probably all of them as well, depending on the situation. So I think it's very case-based situation.
Okay, thank you. So can I get either Dr. Shweta or Dr. Kavita to tell me, I mean, you're in a larger teaching hospital setup. In that kind of a situation, how is the referral? Are there any barriers to referral or any, any concerns or logistics that limit this kind of a care where you can refer a woman, and how is the acceptance?
Being in a
ma'am,
medical, yeah,
Shweta,
okay.
Shweta, you go ahead.
Shweta, say first and then maybe Kavita.
Okay, so in a public, large public hospital, patients' acceptance is quite good nowadays because they realize they have a problem. It's not like olden times what we heard, that acceptance is not good. We tell them that, okay, after ruling out everything, we can give either MHT, for which the acceptance is not very good because they are all knowing about breast cancer relation, cervical cancer, endocervical and all. So they are rather easier, like they are more accepting to go to a psychiatrist because we have the psychiatry department, and they are like all CBT, everything they are giving there only. So we tell them that have a consultation. They may not start you on drugs. They may give you some non-pharmacological methods also. And they come back to us in a week's time and they had like one session and they feel good and something like that. So acceptance here, at least at AIIMS Bhubaneswar, is quite good.
Okay. All right. And is the experience the same in your unit, Dr. Kavita?
Yeah, being in a medical college, we have a menopause clinic. So the menopause clinic will include a gynecologist, endocrinologist, and a psychologist as well. So it is very easy for us to direct our patients, particularly the menopausal age group patients, to this menopause clinic where we hold sessions for them. And if we tell them that you have to go to a psychiatrist, then that becomes a stigma for them. So we just direct them to this menopause clinic, tell them that psychologists are there who will address your problems like mood swings and other mental health issues, but never label them as psychiatrist. So that stigma is still there, but it really depends upon the educational level also. And it is easier for us because the menopause clinic is close to our gynecology unit to send them there, and they will address all these issues where they give talk therapy or psychotherapy.
Thanks, Kavita. So, Dr. Charmila, can I ask you, sometimes when we see this kind of a situation, you also realize that actually support at home is quite weak. And the husband who is now complaining that she's having mood swings may actually be quite unsupportive. And at this point in the stage of life of the woman, when they are going through menopause, they'll miss the lack of support. So how confident are we in identifying that kind of a problem, and what would your approach be there?
We have actually found out that 2 to 3 minutes which we talk in an outpatient department to a patient is not enough at all for such patients. You should spend enough time, because many times when you yourself talk, because she would have known you for so many years, you could have delivered her, she could have so many problems. So you are confident, and many times when you talk to her, they always find a better way of like actually approaching it. But here in our hospital, what we do once we identify such problems, we have a counselor. So we don't say any psychiatrist or anything like that. I'll just say one of my assistants is there. You can just talk with her sometime. And when you talk with her and you give her the information, many times when you give the information, they are quite accepting of that because they would have got some information from the neighbor or from the Google or from Chat GPT, which could have misled them also. Many think they're going to have more of cancers, they're going to become more disease prone now and all that. So when you clarify those doubts and talk with them, it seems to bring down their anxiety level at least. And then when you talk about like yoga, exercise, many don't exercise at all. They think what work they do at home is a form of exercise. So we say you have to spend time for yourself. And I always keep on saying this, like, unless you look after yourself, nobody is going to look after you. So she would have looked after the whole family, but they may not be supportive now. So we tell them go for any other alternate profession also. Take up something which you're very interested in. And some patients, I've called them to my hospital to at least talk to the other patients. So they've got some let out, so they have a person to talk to. Because many times this would have actually cleared the problem rather than going for any medications also. It would have brought down her anxiety, and it may be a cure also, but the talking part, the counseling part forms a very big part of this menopausal transition, because very poorly given information could have actually aggravated the problem also. And those palpitations may be a part of that. We may assume it's because of the menopausal transition, but sometimes there may be that emptiness, which one of them mentioned, and feeling a lack of not having contributed significantly to economically, because now is the time the husbands keep on talking, I worked, you did not work, and all those other things. So we tell them economic freedom is very important. It's not too late to start this thing also, alternate work to keep you happy. Like many people, we have told them to get into, they like buying saris and all that. So tell them to go as a counselor for somebody else. That may also help you out. And because that menopausal transition is many times related to the change in the situation at home rather than what actually has happened to them. So giving the correct information many times helps them out.
Yeah, very, very
I
valid.
would like to add something, Dr. Uma.
Sure.
That it is not a one-time counseling that we need to do. It is like a menopause transition over so many months and years. So it has to be ongoing. And I've seen in my practice, in my department, when I talk to them and spend time with them, they come back to you for more, just for counseling.
Yeah.
So
and
that
many
also.
like to come and visit us at least once in a month. That I'm finding it now. Just come and see, talk with us for some time, and then go. They feel happy about it also.
That's very true, isn't it? I think
Yeah.
as OBGYNs, we become very much their GPs and confidants. And so therefore, we need to upskill to be able to handle all this. Dr. Prabha, I have a question for you. Very often, when women like this have seen a physician because, they've been referred for the palpitations or cardiac evaluation, a prescription for a, sleeping pill, or a mild antidepressant is incorporated into their prescription. But actually, no probing has happened. Whereas as gynecologists, we tend to be a little shy of prescribing an antidepressant or a medication for anxiety. We are always asking the question, and I see it's asked in the chat box also, is it safe for me to prescribe? Physicians don't have any such hesitation, but they write it without actually probing or doing any counseling. So can I just have your thoughts on that?
Sure, thank you. Firstly, I was really impressed the fact that, like for example, in AIIMS Bhubaneswar, there is such a good cross-referral going on. I know the psychiatrists in AIIMS Bhubaneswar, some of them are my students. And I think it's also the kind of relationship you probably share. I cross-refer so many cases to Aruna, women and they've always found Aruna to be a very, very empathic listener. So I think, like everybody has said, like Dr. Kavita has also said, women want somebody to listen to what's going on in their lives. And I think just liaising with them feeling that two doctors are discussing you, talking about you, trying to help you, even that makes a lot of difference. Having said that, coming to your question, Uma, is, see, antidepressants are actually, we are recommending, we are training people to use antidepressants, because mild depression really does not need to come to a psychiatrist. little bit of talk therapy, some simple behavioral activation, CBT techniques can be done by anyone. And it's good for gynecologists also to learn some simple techniques of how to counter negative thinking, how to ensure activity, those kind of things, which are very, very simple, low-hanging fruit. Um, uh, Pills for sleeping, we do not prescribe. Even psychiatrists do not. I should not prescribe. So unless the person has really insomnia for which you can't find any other cause, till then we don't prescribe. Even then we start with melatonin and things like that first before we go on. Benzodiazepines are a no-no because you get hooked on to them and you are not able to get off, and then that's a nightmare. Getting people off benzodiazepines is very, very difficult, and then that leads to so many complications, including brain fog and concentration problems. So I would feel that we do not, nobody should actually prescribe hypnotics like benzodiazepines. If at all you want to do, then low dose antidepressants are much safer. One, because we know they handle vasomotor symptoms also, like desvenlafaxine. We know it handles sleep problems. We know it handles repetitive thinking, rumination, worrying. So starting a low dose antidepressant is okay, but we have to remember that we should always take a past history. So women who had a bipolar disorder, for example, many people will tell you, I had depression in the past, but actually it will be a bipolar disorder, So if you start a woman who has had bipolar disorder on antidepressant, she'll switch into mania. So while you can actually start, there's nothing wrong about it, but taking a good history.
Diligence.
Yeah, and also to maybe work with a psychiatrist. So even if the woman doesn't want to go, you feel she's minor depression, talk to a psychiatrist and say, what are the red flags? What should I find out in the history? How would I know that this is something that I can do safely? So I think it's about learning about safety, side effects, dosing, contraindications. I think once we do that, then there is no problem in prescribing, but it has to be done with care.
Thank you. Thank you very much for that. So I just one more question that to clarify. Aruna, you had said you will start on hormone therapy. So if she does have significant mood swings, is there any concern about starting hormone therapy? And should we be careful about anything when we are initiating?
Yeah, absolutely. Sure. So the first thing is, of course, whether she's the right candidate for starting on hormone therapy straight away. So other than the usual baseline investigations that we would do, which includes the thyroid, the lipid profile, and the LFTs, and the checking for, all the contraindications, etc., any erratic bleeding and endometrial sort of evaluation, etc. Other than that, I think having determined that she's okay to go on estrogens, the most important thing I would like to again determine is, are there any red flags and symptoms for which she will need antidepressants, severe depression, anxiety, and as Dr. Prabha said, switching to mania, etc. If you're talking, are you asking me the medical issues with HRT, or are you talking about the psychological?
I'm just asking, in someone who may also have mood issues, where she may need medication.
Sure.
Is there a concern in starting hormone therapy, or are you comfortable initiating hormone therapy?
Yeah, I'm comfortable starting initiating hormone therapy. Because we do know that in mild depression, it makes a huge difference. I mean, they are a completely transformed woman in a matter of 1 or 2 weeks. So I mean, in terms of starting and the continuous, sequential, cyclical, or the gel or the pill or the patch, those considerations would be individual. But I don't hesitate starting HRT if I feel that it seems to be low grade, just related to estrogen deficiency or fluctuations.
Okay. So
as long as there are no medical contraindications.
Yeah, fair enough. So because we don't have the same concerns as initiating, say, an OC pill on someone who has mood-related problems. We are not worried that and this may actually be beneficial. So I think any other key messages that we want to give more in terms of any logistics or any concerns in hand, because this is a very, very plain vanilla, straightforward kind of situation, but there are a lot of nuances in the care which sometimes get missed. We did have another case, but in the interest of time, I think we will stop.
I have a question
Dr.
actually
Prabha?
for Dr. Prabha. Is that okay if I could ask
Sure, of course.
the entire panel and you and Dr. Prabha?
Sure.
What about anxiety? Because you talked about paranoia. You talked about paranoid. I mean, first of all, narcissism maybe, or paranoia. Just everybody is talking about you, or that sort of symptoms, or anxiety. The other extreme of anxiety and feeling on the edge all the time. How do you deal with such situations? Because antidepressants are essentially for the low mood side of things. And for anxiolysis, is there anything that you'd like to
So
add in?
the treatment of choice for anxiety is SSRI, low dose. So that's our go-to treatment. The other medication we do try is pregabalin for anxiety. So these are the only two medications which we prescribe. So SSRIs are very good for anxiety as well. In fact, the dose which we use for anxiety is much less than what we give for depression. So there is that, especially if somebody has an OC kind of a feature, constantly ruminating, brooding. It's like a repetitive thought, not exactly OCD, but a repetitive thought. They respond very well to low dose SSRI also. But pregabalin is another condition, especially if they have some fibromyalgia kind of symptoms and menopausal symptoms and anxiety. Pregabalin works very well. So yeah, you can do that for if you feel there's a lot of emotional dysregulation, getting very angry, mood swings like crazy, and really like troubling everybody, then sometimes a low dose of quetiapine really does wonders. So, but that you better do it in collaboration with a psychiatrist. But I also feel, like you said, Aruna, that using menopausal hormonal therapy is important. We shy of it a lot, but there are women who do amazingly well with it. And we've shared a few patients who have actually done really well with that. So I think we shouldn't shy of it, but working in liaison with each other really helps.
Okay, thank you.
Uma ma'am, there is a question for panelists. There's a question for interesting question for panelists. Any clues to identify those with pre-existing disorder but not forthcoming or never evaluated?
I think we might be discussing it in the next session.
Yeah, and there are also some other questions which are pregnancy related. I think tomorrow's session will focus on a lot of those topics.
Uma, can I say something?
Of course, Sharon.
It's very important about sleep hygiene. Many of them will be on the cell phones till they sleep, chatting with somebody, or they don't take that adequate rest before they go for sleep. And I think we have to insist on the sleep hygiene patterns which they have to follow. And many times that would have actually solved the issue also. So, and they're not aware of that. They think looking at the YouTube video of something will make them relax. Actually, it will be otherwise. And that is becoming commoner now. Everybody is on the cell phone before they sleep. And the moment they get up, they are on the cell phone. I think that we have to talk to them about the sleep hygiene. And yoga seems to help in this age. Whatever said and done, even a small time spent on the short time spent on that helps a lot as far as that body pain is concerned, as well as the stress which we are having. So quite useful.
Very true. Very true. In fact, Sharmila, I think we as obstetricians are most guilty of having terrible sleep hygiene. And on the last day, have a little bit of a chat around, our own self-care. So we've added that also to this course. So I think, I can't overemphasize what you said.
Yeah.
So thank you all very much for, what may have seemed like a very straightforward, simple case, but there are a lot of nuances that came out of that. Thank you very much.
Yeah. Thank you so much. Thank you.
So
Sheila ma'am, your
we come
comments.
to the end of the today's session, and over to Sheila for her comments, and then the post-test, I think.
I think, Uma, it was so excellent. I think today's discussions and in panel discussion, everybody really come out with the real scenarios. I mean, in our practical experience, And as Dr. Prabha said, that MHT really works sometimes, Sometimes they have very low drive and they are not very active. Even Tibolon also helps. I mean, so MHT also plays a bigger role here. But we have to rule out the other disorders also. But I think most of the aspects very extensively covered today. And I thank Dr. Uma for this and all the panelists and everybody. Meanwhile, I think we discuss, Poonam, can we have the MCQs so that the participants and excellent attendance,
Yes, ma'am.
today.
Yes.
Till now, we have some 260 people still, I think most of the places the postgraduate join, so you may not see that many number. They join in from one device. So I think we will start now. And this was an excellent idea, Uma. I think the case scenario, so both psychiatrist as well as the gynecologist discussing the cases, no? That's an excellent idea. Yeah.
Because it becomes practical, isn't it? Otherwise, we thought,
I think also share the link in the chat box and what I feel that
Yes, ma'am.
the tools, which we will put, okay, on that.
Link has been posted in the chat box now.
It's not there, no? Okay, let them scan this.
They have posted. I think Poonam has posted the link in the chat box also.
It is there? Okay. All of you just check the chat box. It is there.
It's there. Shreya has posted.
Yeah, some people can try that also. It's there, it's there. Harpreet, you can see the link.
And it's also on the screen. The code is also on the screen.
So we give you 10 minutes. Shreya, share the link again. She is not able to see Harpreet. Is it 15 minutes or 10 minutes, Shreya?
15 minutes, ma'am.
Okay, fine. Okay. Dr. Kaur, you can still click on the link in the chat box. Do the double click otherwise. Thank you, Shweta. I think we are done for the day. Okay. Thank you all. Aruna. There are so many people still. Uma, thank you.
Thank you, madam. Thank you. It was a lovely, lovely program, and all the very best for the rest of the 2 days. Such an important program, and I'm so glad that you're bringing it on nationwide. And a very right choice of faculty as well. Thank you.
Yeah, definitely.
I must say, Aruna was there in the initial days when we were putting it together. So, Aruna shared some of the credit of the conceptualization of the course originally.
Thanks, Ashlesha.
Very good.
Thank
Very
you.
good.
Thanks, Dr. Uma. Good to see you at least virtually after a long time.
I know. It's really nice to see.
So I get an idea now, Aruna. I get an idea. 22nd conference August, ICOG campus is on mental health, and I am giving you all the responsibility.
Oh my God.
Okay, Dr. Uma. My
Responsibility.
ICOG annual conference.
We can plan in August, yes.
Yeah. Okay. Where we can give all these tools and questionnaire and everything. A small booklet, no? ICOG campus, we come out in every conference. Aruna, you can start working with Dr. Umaram, Dr. Ashlesha, as well as Madam Prabha.
Okay. Yes, ma'am. I'll call you. I'll get more
Yeah.
details about
So that
it.
just came to my mind now. So I think we have to tell the answers. Yes, Dr. Uma.
Oh, I haven't finished.
I think it's being projected.
Yeah. I think they can see it. No, just scroll it. Yeah. Lata did not join.
I think Lata is for the next day.
The only one I didn't understand was disenfranchised griefs. Please educate me. I think I missed that part. Ashleisha, what is disenfranchised?
We'll be talking about
Disenfranchised.
grief tomorrow, so we'll talk a
Okay.
little bit more.
Okay. Acha, theek hai. I thought it
Essentially,
might be
just
the
in terms
partner.
of, I mean,
The partner.
quickly to answer your question is when you're grieving for something that you're not necessarily very attached to. So that. But anyway, we'll talk about it more tomorrow. I
Okay,
think it's
all
the
right.
end of the session, so I don't want to upset.
I think that
Everyone's head
grieving is
must be
very,
full now.
very
So
important. Grieving, because in India it is never taken care, The closure never happens, okay? People are not aware, that is never there, and nobody knows how much the woman is suffering.
That's true, ma'am. Our bereavement support is very poor, very poor. But thanks to the FOGSI president, Dr. Bhaskar Pal, they've come out with a nice module now. I think you know about that, madam. I contributed one. I think you know about that, na, ma'am? Sheila, ma'am?
Which one?
Modular teaching jo kar rahe hain, Dr. Bhaskar Pal. There's one about bereavement care.
Okay.
Stillbirth and bereavement care.
Acha, in that Reach CME, it is there?
Talking about Reach CME.
Yes.
Okay, we can also have, I will see if I can have a look at those PPTs. But we will come out with this ICOG campus. I think that will be good.
tomorrow we are addressing perinatal grief and bereavement.
Yeah. Thank you all.
So,
Thank you.
Sheila ma'am, with your permission, can I propose a
Yeah,
formal
please.
vote of
Yeah,
thanks?
please.
So, my thanks first to Sheila Mane ma'am for giving me this opportunity, Prateek sir for guiding us through this wonderful day one of the ICOG course on mental health, Dr. Bhaskar Pal sir for being the guiding force, Dr. Ashok Kumar, Sadhna Gupta ma'am, Suvarna ma'am, of course. And my heartfelt gratitude to Uma Ram ma'am for always guiding and selecting wonderful presenters and faculty for this program. Sarita ma'am for joining us and giving her blessing. Shashi Kabra, my co-convener for this, and Dr. Lata Venkatraman also. And my coordinators for today, Shaija, Smita, Kiran, ma'am will be joining us tomorrow. And I'm really grateful to all my chairpersons, Dr. Jyotika Desai, Dr. Seema Hakim, Dr. Madhuri Patil, Vaishali Korde, Dr. Shashilata, and all my speakers, Prabha Chandra ma'am, Ashlesha ji. Prabha Chandra ma'am, you have been a wonderful discussant for today's program. And my thanks to Runa Benjamin also. Shamima ji, thank you. Charmira ma'am, my heartfelt thanks to you. Shweta ma'am, Aruna ma'am, thank you for joining us. Kavita, dear friend, thank you for joining and giving your valuable inputs. And I am really thankful for the backend team for providing me wonderful this thing. And my sincere thanks to all the delegates who have joined us today in large numbers. And we really hope to see you tomorrow also. Sarita ma'am has joined again. Will you like to add something, ma'am? Thank you so much.
Oh,
Thank you,
I think
everyone.
it was wonderful, and I think it's been a great start. Thank you, everyone. I'm
So
sure
see you.
tomorrow and day after will be
Yeah.
just as great.
See you soon tomorrow again at 4 p.m. Thank you so much.
Thank you. Thank you for inviting us. Thank you.
Thank you.